in the room that shared a lot. So this morning, I was asking myself, how did we perceive, how did we actually get to this? What did yesterday mean to us? And because you can imagine that a conference like this has people in the back that are noting each and every word, and that are noting all the best interventions that were mentioned yesterday. And I've gone through them and they were so nice, well written, but it doesn't probably represent the stories that are behind all the minds that are sitting in this room. So today I would like to start with asking you the questions. In one word, not two, not three. What did yesterday mean to you? In one word. I am a teacher and I always tell the students the art of answering a question. If they ask you what was the diagnosis, I want to hear it's malaria, it's HIV, it's preeclampsia. I don't want to hear, the patient like, no. So in one word, what did yesterday mean to you? Just give a microphone to any of the participants. You don't need to raise your hand, just give a microphone to anyone. Like the gentleman there with a gray suit. He's in a mask if you cannot identify him. He's sitting just... Okay, whoever, just give anyone the microphone.
Passionate.
Great.
Thank you.
The other one, the lady in green.
Here. Yesterday meant to me digital. Better health.
Okay, I'll take it for now. But yes, go ahead.
Progress.
Progress, excellent. Someone else, we want to hear as many as we can. There's the microphone here, please.
There is one here.
Okay, go ahead.
Say role model. I know it's 2 words, but
I'll take them, thank you.
Informative.
Informative, amazing.
can you hear me?
Inspiring.
Inspiring. Someone was inspired, and I was inspired. Thank you so much.
Innovation.
Innovation. Wow.
Possibilities.
Possibilities. Excellent. Yes, there are so many hands.
One citizen, one record.
I don't know if I would tell them.
Motivating.
Wow. Thank you. Go ahead.
Hope.
Hope.
Digitalized.
Oh, great. Someone was digitalized yesterday.
User-friendly.
User-friendly.
Perfect.
Was perfect. All right. I saw someone. Can I ask you, please, can you give a microphone to this person there? Someone is in green. I have a question for you. Morning. Good morning.
Good morning.
You good?
I'm well,
Are you
thank you.
feeling very well?
Yes, very
Did
well.
you get some coffee?
Yes,
Very
please.
good. So I saw you yesterday, you were in this meeting, and you really participated. It was great. I want to ask you a question. You just step out of the meeting, and you're meeting Bill and Melinda Gates. He got the money. You're meeting the director of DFID. He got a grant. You're meeting the director of USAID. And they're just chilling, having a coffee. And they give you a minute to talk to them. I'm telling you, to get to these people, you need an audience of months, because they are not actually months, probably a year at some point. So they ask you, as a person who just coming out of that meeting, they have this chunk of money, these grants they manage, and they want a reason to why they should invest their money in digital health. And you've got a minute timed. At the 49th second, you stop. So, go ahead.
Thank you very much. I would tell the development partners, either DFID or Bill and Melinda Gates or any other development partner, that investing in the health sector is worth it in a manner that it is rewarding to everyone. We still have challenges to do with infrastructure, to do with architecture, to do with health cloud, to do with revamping our health systems existing. So if we have taken a direction to do it right, we need the funding to do it right and do it first, and also to save more lives and reduce the burdens that our doctors have because they are not, they do not have access to the right information. The other thing, I would convince them that actually it's not convincing, it's
50
clear.
seconds.
It's clear that our country is transparent, good governance, and the top leaders are behind helping digitizing the health sector. So it is worth it investing in the health sector digitization because you're bridging the gap between the patient and the doctor, and you're bringing medicine. Thank you.
Excellent. I heard two words from the minute discussion. One is the return of investment. If you invest in health, there will be a return. Second, bridging the gap. Thank you so much. Well, if I'm Melinda and Gates Foundation here, would I give the money? Maybe. I can invite you for the next meeting to give me a full project and see if that is going to yield all the results. So I've seen some young people in the room. Yes, please, that one. Yes, yes. Hello, good morning.
Hello, good morning.
In my eyes, you're very young.
I am.
Very good. So, you are invited at the cabinet meeting. His Excellency is sitting there chairing the cabinet meeting.
Okay.
The ministers are there and all other representatives of the cabinet. There's a debate that we have never won a World Cup. And they think that if we invest in handball, we might win the World Cup. For your information, Denmark and Sweden are always playing for the World Cup for handball. So, now, there are two things. The Minister of Health is pitching for digital health. And the Minister of Sport is pitching for handball. And you're here to convince the cabinet that the Minister of Health should be heard and the investment should go to digitalizing health system. You have a minute to convince the cabinet members. Go ahead.
Thank you very much, Mr. President, for giving me this moment to speak on this. And if I would say something about the current situation with the Ministry of Sports and football in general, I would opt to the Ministry of Health and the digitalization of health, because this is very personal to me. Recently, a grandma from Karongi had a transfer to come to Kigali, and this is a paper, and she lost it when she was coming here. And if our health system was digitalized, I believe that she couldn't be seen by the doctor by then. And that is a hindrance. And I believe that if the digital health was, if the health system was digitalized, she'll be able to be seen. It will reduce the paperwork, and it will better even the business development of the country. So the Ministry of Health and digitalization of health, I would be for it. So please, thank you for the cabinet and Mr. President for, please think about it. Thank you very much.
Thank you so much for sharing your story. Yes, for sure. I'm sure that your grandma would be seen and wouldn't be asked to go back home to bring a paper And I don't know, I still feel like we can opt to discuss more because we also want to win the World Cup. But thank you so much. But great question. So you've spent, so can we, anyone in this side want to answer my question? Can you come to this side? Anyone here? Can I pick? Okay, there is a volunteer. Yes. Looking in my eyes, you look like a medical student or a very young person. I don't know if you're medical or pharmacy, but...
Yes, I am a medical student.
Very good. So the University of Rwanda has a vice chancellor. And the vice chancellor is debating whether the university funding should be channeled to research for the medical students or to research for us, the faculty. Because we need the money as the faculty. And the medical students, we need to teach them. But you're here saying that, no, the medical student can do research. Give him an idea to why they should invest in research for medical students.
Okay, thank you, Vice Chancellor, for this opportunity to talk on how medical student involvement in research is a key. So here, as a medical student, you know we are the future of healthcare, and I do believe that if the university decide to invest in medical student research, this will result in a long-lasting solution where their involvement today results in a future very powerful production of research output, and this will not increase their experience in research, but it will also contribute to the academic output of the university in general. Thank you very much.
Thank you very much. So please, the right people have heard you, don't worry. And they are seated here. So don't worry, the research is going to be also channeled to the medical student. Can I ask my sister there to take a microphone and answer my question? I'm sorry if I'm putting you on spot. So my last question to you, you're in a supermarket and you happen to meet the Minister of Health. He's also shopping and you're shopping. You know him from the TV. And he drops something and you happen to take it and hand it to him. At the time you're talking to him, you want to pitch to the Minister of Health as a person who have participated in day one. You want to tell the minister one thing that he should be doing right from this conference, and he's ready to do it. What is that thing that you want? What is that action that you want the Minister of Health to take right from here if you participated in day one?
Thank you. I think what I would ask the minister to think about would be in the digital world, I think the healthcare providers understand what it is and what it's about and the importance of digitalizing the health system, but the recipients, the patients, the public, the people of Rwanda do not really understand. So I think a campaign to the people of Rwanda would be in order to make them really understand the importance of a digital health system. There are benefits, what they would be getting from a digital health system. Yeah, I think
Great, time. Can you appreciate everyone? Thank you so much. Thank you so much. We've got a lot of recommendations and lots of those points, we've actually pointed them down and they are well written, and all these takers are going to be shared to you at the end of the meeting. So thank you so much for coming for our day 3, because actually day 1 was not here. Day 1 was at the university, then yesterday and today. So today we're going to kick off our day with other great speakers. We have speakers that are going to talk to us now, but also we're going to have a great panel discussion like yesterday. So to start the day, we're going to start with someone who is a professor here in Rwanda. He's a scientist and a researcher. He's currently the executive secretary of Rwanda's National Council for Science and Technology. Prior to this appointment, he served as the Minister of Education of the Republic of Rwanda. And prior to this, as the Minister of Health, he coordinated the Eastern and Southern African Centers of Excellence project funded by the World Bank in 8 countries. And those projects were to support research and education in 16 universities. He was a recipient of Fulbright Scholarship. He obtained his doctoral degree from the University of Witwatersrand in Johannesburg, South Africa in 2007. And he previously worked in the Region Alliance for Sustainable Development. This is none rather than Professor Eugene Mutimura. A round of applause as we welcome him as our keynote speaker this morning.
I am very delighted to speak after a light moment of hope, of progress, and digitalizing health sector for innovative practices. So I want to thank the Master of Ceremony for his very engaging conversation. Thank you very much. Distinguished leaders and colleagues that are participating in this symposium, ladies and gentlemen, I would like to thank you very much in the first place to give us an opportunity to speak on health research and policy, whose theme is digital solutions and innovative practices for a better health. Today's theme is on innovative practices for better health. I would like to bring the attention of the participants in this symposium that the government of Rwanda's Vision 2050 quite links up with today's theme, but also overall theme of the conference. Rwanda aspires to be a middle-income country by 2035, with a GDP per capita of over $4,000, and upper and high-income country by 2050, with a GDP per capita of over $12,000. I should say it is not merely about numbers in terms of economic progress and prosperity, of how much citizens of Rwanda can be able to afford and what they value, but it's about the Rwanda we want, prosperity and high quality of life for Rwandans, and that is the vision of our nation. Therefore, Rwanda's vision and goal quite links up with this conference. Once again, I should take the opportunity to thank the organizers of this conference for choosing this pertinent theme. One of the mandates of the National Council for Science and Technology is on advising the government in terms of policy, legislation of science, technology, and innovation, as well as research. And so the government of Rwanda approved a policy to support research growth, but also knowledge creation. And so in 2020, the government approved the policy on science, technology, and innovation, which is an adoption of 2005 STI policy that was improved in order to encompass regional and international perspectives. Let's note also that Rwanda is a signatory to African Union Agenda 2063 and the Lagos Declaration to invest in research and support research growth, knowledge creation, technology development, and impacting on the lives of citizens through innovative practices. Last year, we launched a report on research and development survey nationally, and we realized a lot of progress is being made in Rwanda in terms of R&D investment. Over a 3-year period, there was a change of investment from 44 billion to 70 billion. That is 0.66% to 0.69 gross domestic expenditure on R&D, which is an improvement. We are not yet there, but it is a work in progress. The number of researchers per million population also in Rwanda increased. The number of female researchers also increased because we are very pertinent when we talk about science and gender. And so research, in terms of knowledge creation and deepening, technology development is changing from time to time. And we are very happy because improving innovation performance ecosystem cannot take place without funding mechanisms. In 2018, the government of Rwanda established a funding mechanism called National Research and Innovation Fund. Currently, we are funding over 90 projects for over 4.1 billion commitment. And I'm happy to note that almost 30% of these projects are in the health sector. So there are various projects on research, production of molecular-based point of care, for SARS diagnosis, development of acid-based rapid diagnostics, and several projects that are being carried out that we are funding. And so we are very happy that we see progress, and there are anticipate a lot of innovations in terms of health and innovative practices improvement. However, we should say that there are challenges that we see. But before I talk about the challenges, let me say that we have also seen a lot of progress, particularly in the health sector. Most of us are quite aware that every 2 years we do a national survey of the status of science, technology innovation in the country. And so one of the reports we launched last year, we actually found out that adoption of emerging technologies, particularly in the health sector, but also in other sectors, is improving. And so, for instance, adoption of technology in terms of telemedicine is remarkable, revolutionizing healthcare system in Rwanda, and the rate of utilization is increasing from time to time. And telemedicine is significantly improving the quality of lives and in the healthcare sector, improving accessibility and efficiency. And so patients may not need to travel to all parts of the world, but they may be supported where they are, decreasing geographic barriers, providing better clinical support and care, and improving patients' outcomes. It is also true that we quite know, as we heard from speakers yesterday, that during the high peaks of COVID pandemic, a lot was done, and one of the techniques used was use of robotics as an important technology in management of COVID in various ways. In the screening, instructing patients in different ways, even those who are not patients, telling them how to put on masks where and so forth and so on. This is a lot of progress that we see are quite linked with the health sector in terms of innovative practices. We are also quite aware that since 2016, adoption of technology in terms of drones has helped a lot in Rwanda, delivering blood to long-distance areas, I think now medicines, rural mountainous areas, supporting the lives of citizens, mothers, under 5-year children, potentially reducing maternal and child morbidity and morbidity rates. These are some of the practices I believe that we should cherish, we should support, that we should continuously benchmark on. However, there are challenges, and as the leaders, as the scientists, as we work today, as we discuss, as we deliberate, we should know there are challenges out there that we should seriously consider. The COVID-19 pandemic that has resulted into unprecedented global tragedy, human loss, impacting on the socio-economic lives of people has taught us a lot. The available evidence suggests that infectious diseases, potential epidemics, and even potential pandemics may occur in the future. You certainly remember and recall that in 2014-2016, Ebola virus disease was very common. It struck Western Africa. I do recall from my previous work that one of the gentlemen in Nigeria, Professor Happy, was at the Christian University, was very enthusiastic in providing diagnostic tests for Ebola virus disease. There are also other viral diseases that may occur and may spread to tropical world and other places of the world. And so as we deliberate today on innovative practices, I believe that Rwanda and Africa and other countries should form strong partnership with global partners to ensure that we have innovative, holistic approaches to pandemic preparedness and fight future threats. And so building resilience in our institutions in terms of technology resources, infrastructure, human capacity is very important to build resilience in terms of diagnostics, in terms of vaccine manufacture, in terms of pharmaceutical manufacture is very important. Secondly, the United Nations Conference on Trade and Development provided a report in 2020 indicating what will be the frontiers of technology in 2030. And so yesterday I was happy that speakers talked about the importance of multidisciplinary collaborations of clinicians, epidemiologists, engineers, and other professionals to think through how can they work together to tap into the opportunity of various emerging technologies, data science, robotics, artificial intelligence, that are clearly going to impact on the lives of the citizens, to utilize them efficiently, adopt them in ongoing innovative practices in the health sector. And finally, this has been talked about again and again. I believe that digitalizing, ensuring that the medical systems are better strengthened in terms of care so that care is much more easier for our citizens is very important. You book an appointment online, you receive the services, you pay online, you can timely be discharged and be trusted wherever you are going to ensure that you meet the bills is very important so that the data-driven policy and digitalizing of health sector becomes a norm. Once again, as the leaders, as the scientists, as the colleagues, we will always be delighted to support you. I thank you for organizing this conference, very engaging, providing a lot of hope, progress, and digitalizing the health sector. I look forward to fruitful engagement. Thank you.
Thank you so much for those great words of hope, as you mentioned. And I like that Rwanda is growing as a country that is taking its decision according to the evidence-based informations. And from the speech, I heard that the researchers in Rwanda are actually are going up. So if you're not a researcher and you're in this room, you're missing out in that number. So the next time they make an account, make sure you're also part of it. So our next speaker is going to talk to us about research for a resilient health system. And this talk was prepared by Dr. Parfait Warilaye, who is the head of Department of Planning and Monitoring and Evaluation and Health Financing in the Ministry of Health. But he's here represented by Mr. Darius Uzabakiriho. And Mr. Darius Uzabakiriho is a pharmacist and a health system strengthening expert who works as a health system analyst from the Ministry of Health. He started working there in 2019. He was serving as, before that role, he was serving as a National Pharmacy Council from the Pharmacists Council. And Darius Uzabakiriho has an extensive expertise in the areas of policy analysis and health system research and program design. He's here with us today. And please, sir, the floor is yours.
Thank you so much, moderator, for that great introduction. I'm very happy today to give you a presentation that was designed by the Ministry of Health, and the presentation is about the efforts we are doing to make a health system more resilient using generation of evidence. And this is actually drawn from the country's aspiration in the Vision 2050, where we aspire as a country that by 2050, the country will be having a health system that is resilient and that contribute to the growth of the economy of Rwanda. Next, please. That's to mean we will position the country as a center of biomedical research, and there will be development of critical skills in terms of STEM sectors, and the growth domestic expenditure on research will grow to 2% from the state in 2020 that was 0.4%. And then Rwanda will continue to be a destination of world-class universities and research institutions, and we will build research infrastructure and groom researchers in the country. And of course, we want to have a country where research are aligned with the demand of the sector. Next, please. This will be achieved through a certain principles. And these principles include that we want to own researches that are conducted in Rwanda, and we require, as the Ministry of Health, that whoever is conducting research collaborate with our scientists in Rwanda. And we continue efforts to build the capacity of researchers in Rwanda. We also increase the financing, and we bring the coordination of research to ensure that the research are conducted of good quality, and also we monitor those research that are conducted on vulnerable participants. And of course, we have made a research agenda. Next, please. And in our research agenda, there are 4 pillars that are helping us to position the country as a resilient country using evidence. And 4 pillar is to bring up opportunity and resource mobilization for research. We translate research findings into policy, and we ensure that we have a streamlined research environment in Rwanda, and we mediate research capacity building for the conduction of researches. So far, the country has registered milestone in research. When I say research, these are research in health sector. And we have made up a National Center for Health Observatory, and we have had a project called District Research Challenge Fund. And of course, we are continuing to build the capacity in terms of research. And we have a booklet to guide the clinical research implementation. And we are translating evidence into policy in what we have made as a national research agenda. There are other ongoing efforts for health research, and these include research grant writing, clinical trials site readiness, the Center for Genomics, Computational Biology, and Bioinformatics, and of course, data policy and public health bulletin. Next, please. There are key priorities that we consider as a sector for research, and these include genomics and bioinformatics, digital health and telemedicine, validation of biomarker-based risk prediction models, use of unmanned aerial vehicle for health purposes, the mechanism of protective immunity. Next, please. The biomedical research and drug discovery through biomaterial in clinical practice, the demographic survey system, the evidence-based care, and of course, the clinical trials and action researches. These efforts are coordinated using that framework. That's to mean the government, the Ministry of Health, the Rwanda Biomedical Center, we are working together with academia, mainly the University of Rwanda, and the industry to conduct research that can generate evidence. And this, our philosophy is that we train people, we mentor them, and we engage the private in what we call PPP. Next, please. Before I conclude, we do believe that when we conduct research, they need to be reported. And in the Ministry of Health, especially in the planning department where policies are developed, we encourage all researchers to report. And we have developed a template for policy brief. And we always encourage research to report in terms of policy brief. And that is because I quote the Julio 2010, where he stated that we need to mobilize the power of ideas in order to influence ideas of power. That is to say that the idea of those with power to make decisions. That's to mean when you conduct a research, you have already identified the problem and you generate evidence. If you don't use those evidence to influence those with power to make decisions, your research is not contributing to the health sector growth. That's why we have developed a policy brief template. And the policy brief is actually a document that outlines the rationale for choosing a particular policy alternative or course of action in the current policy debate. In this forum, I would like to introduce one of researchers. He is a clinical officer, and the clinical officer has conducted a very small research. But as the ministry, we have helped him and other fellows to use those findings in generating evidence that can influence the policy. And this was a project conducted in partnership with the National Center for Health Observatory. If you allow, please welcome Mr. Theonest to address you, showing how the ministry wants findings so that we can make policies. Thank you so much.
Hello. Hello. Can you hear me? Hello. Hello.
We're trying to get Ernest to present his online. Is he ready? Good, thank you.
So, I'm ready. Can you hear me? Thank you, Theonest, as my colleague Darius said. I'm presenting a policy brief. It's a policy translated from a research conducted in the Rulindo district in the northern province about teen pregnancy, a call to action on burden and linked health problem. So this is a policy brief we developed with other colleagues of mine under the District Operation Research Challenge Fund conducted in 2017. So as we move to the next slide, we find that from this research, the evidence showed that in Rulindo district, even though there is an effort done by the government to prevent teen pregnancy, still the situation hasn't improved yet, as we find 5% of all deliveries among deliveries are teen. So still the decline is slow compared to the proportion we had in 2012. Again, going to the magnitude of teen pregnancy in Rulindo district, we find that the complication among teen mothers include low attendance of antenatal care, which is at 26.6%, compared to adult mothers, and we find that also there are a number of unsafe abortion where these teen mothers commit, which is 1.1%. We also find that there is a high risk of acquiring HIV, where we find among those teen mothers, there is an important number of HIV positive cases. We also find that there is a complication during pregnancy, about 34.4% of teen among teen compared to adults. They got some of the complications, including delivery with C-section, delivery with episiotomy. So, going on newborn, please go to the next slide, please. Thank you. For the newborn, we find that they are prone to complications, including many of them are around 7.6%. They didn't cry after delivery, and there is a risk of neonatal mortality, which is 3.6%. And we find among the newborn, 90.1% born with low birth weight. These are the complications we have identified among teen mothers who delivered in Rulindo district of Northern Province. From there, we proposed some of the strategies to alleviate the issue, including the comprehensive sexual reproductive health. We wanted to propose a targeted comprehensive sexual reproductive services which target these teen mothers. We also propose to strengthen the integration of SLH in primary and secondary schools programs. As you know, in Rwanda, almost 100% of teens are at school. We also proposed to improve the adequate health services to teen mothers with much focus on improving access to service and the availability of youth-friendly sexually productive health. Finally, we proposed to improve child protection, and of course, with much emphasis on fight gender-based violence. So from this policy brief, there is an implication of these research findings which need to help the intervention from the police so that we may improve the life of the teen. So we need to promote a multi-sectorial collaboration as well as adoption of innovation and technology. As we know, the technology is growing, so these youth, these teens are accessing to technology. So the message, the social and behavior change communication should embrace the technology so that they may access the preventive message to prevent teen pregnancy. And again, we need to improve the training side of healthcare providers so that they may understand the care and the proper management of complications among teen pregnancy so that we may reduce death. So we appreciate the Ministry of Health for the entire process they gave us through the training and the capacity building since the development of protocol analysis to the level of producing this policy brief, which targeted decision makers at the decentralized level so that we may improve our healthcare system in Rwanda. Thank you so much.
Thank you so much for sharing your tangible work that you've done that is actually giving us an idea of how, as a junior, as a clinical officer, you can use your effort to translate research evidences into policies that can serve a country. Thank you so much for the team. Now, we've talked much about digitalizing health systems yesterday, and today's speech from Prof. and even the research that has been done by the Ministry of Health is linking us that there's no way we talk about research without being innovative. Innovative is thinking that there's something that you don't know, that is existing out there, and you look around. You do not sit comfortably in your comfort zone. You think beyond what is the scene, and you innovate. So now we've got someone who's going to take to us through innovative approaches to strengthen the health care services. And this is a person who is the executive director of Partners in Health, known locally as Inshuti Mubuzima. He's a medical doctor who started caring for patients as a physician at King Faisal Hospital. He has led the decentralization and integration of HIV and NCDs, and mental health, oncology, and surgery interventions within the northern district of Burera, whose public health systems has a catchment area of over 3,000 people. From 2013, he was a medical advisor to the Ministry of Health in the National Human Resources Program, where for the 2 years before he joined the PIH, he supported the government efforts to develop a training program to produce cadres, qualified health care professionals, in collaboration with 20 US institutions. Prior to his appointment to his current role as the executive director, he was the chief medical officer for Partners in Health, where he oversaw national mentorship and quality improvement interventions. He successfully with the effort, reduced the neonatal and child and maternal health mortality and translated into improved national policies and protocols. His current role, he leads a team of over 200 people tasked with improving the quality of care provided to patients in oncology, NCDs, mental health, surgery, maternal, neonatal, adolescent, and child health by developing equitable and scalable and patient-centered innovations in these clinical areas. He also serves as an adjunct faculty member to the board of directors of the University of Global Health Equity. You know that person? Would you like to shout his name? I did not mention his name. Would you? Let me save you. He's none other than Dr. Joel Mubirigi. A round of applause as we welcome him.
Thank you very much, MC. That was long. It was as if you are listening to your own eulogy. Good morning, everyone. It's my pleasure and honor to be here on this important conference where we're talking about research, innovation, but with the main purpose to improve service, to improve outcome to our patients. The presentation I'm going to share with you, I have a few slides that I want to share with you today, but I want us to focus really on the main principles that have been guiding our work in Partners in Health and use some examples to highlight those efforts to innovate. A small heads up to you is sometimes when we talk about innovation, people think about a discovery of a new product or a discovery of a new machine, equipment, or whatever. But in our context, in Partners in Health, we look really into innovation in looking at what works to make sure that within our context, and usually almost every time in different countries where we work in Partners in Health, the context where we work is really within underserved rural population. And with that, we don't even have to make major biomedical discoveries, but our focus is how do we innovate in a way we provide health services to make sure that the biomedical discoveries that are happening reaches actually those population. So that is really the innovation that I'm going to talk about today. So I just want to give you that scene. If we can have the slides, I think they have it ready. So in my slides, I will start with some principles that have been guiding our work. And I'll summarize them in three. The first, which we are lucky and blessed in Rwanda, we are not short of, which is to be ambitious on behalf of our patients, to have an aspirational plan that look at how do we provide the maximum, the optimum, not the minimum, but the optimum service to the patient that we serve, and develop a system that serves that purpose. That's the first principle. Really think ambitiously, really think with the optimum idea in mind. The optimum idea in mind that is not looking into vertical programs, that looks at integrated and horizontal programs. The optimum system that does not look into prevention versus care, but that looks at both prevention and care. Optimum service that does not focus on access at the cost of quality, but look at access and quality together. That is the aspiration. And then work toward that aspiration through different ways, through different partnership, incrementally. And I'm glad that Professor Mtumira mentioned that in terms of how the GDP, how the income in country have been increasing, and the target that we have to become a middle income country, and also the presenter from the Ministry of Health that presented on how the target to increase research budget, all of those elements should come and serve that aspiration. As we grow, as funds improve, they come to serve that already ambitious goal that is there. And in Partners in Health, when we're thinking about health system, we look at them at these 5 S's that we call the 5S, that look at human resource within our context and within the burden of diseases. What are the human resources that we need? What are the skills that they need? At which level? And how do we build those skills? And how do we transfer certain level of skills wherever necessary? And the quantity of those staff to be able to provide that optimum service that we are looking for. We look at staff and other staff. I don't know how to pronounce those different stuff and stuff. Equipment, what are the equipment that are needed? From simple things like a pulse oximeter to bigger thing, like an oxygen plant and so forth. And here I'm using words that have been in our ears for 2 years now with COVID so that we keep our memory fresh. So that is the stuff. The space, that looks really into the infrastructure. All of these things happens in a place. It can be a health post close to the community, up to a referral hospital, or from a small laboratory at the health center up to a national laboratory. But that space and staff and stuff needs to be linked through a clear system. Need to be linked through a clear system that provide all the needs. We talked yesterday about digital health, from information systems, supply systems, and so forth. We can name them. And we talk also another important S, which is social support, especially for our context. And this is linked with the last point, principle, when we talk about what really works in the context where we are in underserved population. Thinking about the social determinants of health. A health system that think about the social determinants of health as well as part of the delivery of care is extremely important. That's the first principle. Second principle, as we do that, we need to look at consistently with objectivity and humility, question ourselves of what is working. Sometimes we start with an idea and implement them, but what we realize that in real life, there is much complex things than that. And that's where the importance of implementation research here in the context of innovation. That will include translating policies into practice and see if those policies in practice are functioning and what are the limitations for those policies to be implemented. But also looking at evidence-based things that have been already proved to work in certain contexts and test them to see if they work in our context. This is the importance of implementation research. So in our way we innovate about health services, we really think ambitiously, and also with a clear process on how we assess what works in the context of where we work. And then the third, next slide, element, we look at it, keep in mind that actually our aspirations are, or the aspiration that we have is a moving target. What Rwanda was aspiring to get to as a health system 10 to 15 years ago is not what we're aspiring to today. There is a moving target. And there's multiple examples that help us or remind us on that fact. At some point, reducing maternal and neonatal mortality was and still is an aim and target, but the more we reach it, the more we are getting there, the more we realize that there is increasingly newborn that we are keeping alive at the moment of birth, but who are at risk for development for the rest of their lives. The policy brief that was released around teen pregnancy shared some percentage of prematurity, birth asphyxia, and so forth. We are keeping babies alive at the time of birth, but what happened after? Is the health system adapted to take care of these babies and help them and the parent to thrive? This is a moving target. And we need to make sure that as we are reaching a certain stage, we are moving also to the next stage. And that's where the ideas of innovation, for us, at least at Partners in Health, comes from. And I'll talk a little bit, next slide, to the pediatric development clinic that we have been developing in the Eastern Province. The example of the pandemic about COVID, we realized that at some point we were okay to have intensive care in few referral hospitals, or having oxygen plants in few provincial hospitals, or having robust diagnostic capacity in only few district hospitals, and that could serve the purpose. But in the 2 years of COVID, we realized that we need to do more than that. And how do we upgrade? How do we review the health system? This is the moving targets. So the idea of being aspirational, the idea of being objective and clear about what works actually in the context, especially for those who lives in underserved, mainly geographical or economical situations. Then the clarity in mind that the goal or the aspiration is a moving target. And that's where the work of policy brief and then working on how we put the policy in practice comes in. And that exchange has to be, we need to find a way to make it really, that circle, work promptly and inform each other promptly. Next. So here, with those principles, I'm going to move through some certain examples. The Pediatric Development Clinic, I already talked a bit on why the idea and how it became a moving target. As we're keeping newborn alive at the time of birth, realize that some of them might come to life with some complications and be at risk and require an adapted health system to do so. So we look at what are the, if you remember the 5 staff, what are the skills that we need to have in place in that place? What are the skills that the nurses and the doctors, the GPs in a place like a district hospital, this is a picture from the Kirehe Hospital, and this is a PDC, Pediatric Development Clinic in Kirehe. What are the skills that the team that works there needs to have? And what is the right combination of staffing there? We realize that we cannot deal with these babies with their parent without a social worker. So the clinic is run really basically by a social worker, a nurse, and supervised by a general practitioner, mentored as well by a pediatrician. So that combination, we need to clearly define what is the role of each one and what skills we are expecting from each one of them. Then we'll look at the staff. What are the equipment? What are the things that we need? These kids might need, as they grow, a certain element to help them develop, things that they need to play with to help them develop their coordination as they grow, support their parent in training for speeches, how we train the babies, some kinesiotherapy service to help the baby develop their, their limbs and so forth. So there is a certain number of equipment that are needed. How do you monitor the nutrition of a premature baby is different on how you monitor the nutrition status of a normal baby. So we need to adapt all of those things, and that's how we are becoming innovative. And you look at space, of course, which is there. We have to have a dedicated clinic to be able to provide that service, and as well as the systems that need to be built around. How do we capture information on the growth of this child, or these children? How do we get it integrated within the hospital information system in general? How do we link that with the health center and the community where we send these patients back home? And how do we link the information through that process? Developing the system around that. Then we looked as well at the social support. Obviously, for most of these families who already in general will be in a very difficult economic situation, the coming of a baby that should have been a moment of joy and hope for development for these families sometimes become a moment of distress when the baby is coming with these complications. And usually what we notice in the community where we work, because we work close to them, This will tear apart families. Mainly men, husband will leave their wife and not taking care of their family anymore because they condemn the curse, let me use that word, of having a baby who is not developing, growing to the women. So how do you develop a system to support that socially in that context? And this is the ambition that we need to have when you think about health system, to incorporate all of those elements. Next. And I think I mentioned, I'm probably one step ahead of my slide. So the next slide, this I already talked about. I want to talk about mental health. Mental health, clearly in our country, in Rwanda, we have clear ambition that these services has to be decentralized and at the community. We wanted to move away from this psychiatric asylum way of managing mental health because evidence is already out there that this approach actually provides a better outcome in mental health. But then from policy to practice, how do you do that? What are the elements that need to come in? Remember, again, the 5 S's. What are the ingredients that need to be there? And how do we put that in practice? And this has been an effort where we have been innovative and thinking about moving target. You know, we focus at an initial time on providing pharmacotherapy closest to the patients, up to the health center level. And there have been a lot of progress in having mental health medicine into a list of essential medicine through a supply system and so forth. But we realize that, obviously, in mental health, the care is more complex than that. What about psychotherapy? And what are the level of psychotherapy we can bring to the level of a health center? And there is tools there. There is things that have been proved to work. The WHO Problem Management Plus that look at support for depression and so forth. How can you use a tool like that and adapt that and provide the training and assess how this is working? Moving target. From a place of decentralizing, from a place of making sure that pharmacotherapy is happening, to a place of including now within that therapy a psychotherapy element, moving target. So that mindset have been the combination of elements that have been helping us to innovate in improving the service delivery at the point that is closest to our patients. And you can see through that line, since the beginning of the program in 2015 to date, we have close to 4,200 patients that are actively coming to clinic for their follow-up that will follow clearly. The system, information system, developing a robust electronic medical record that encompasses mental health information. So all of those efforts have been pushing us one step to another to really improve the service delivery and be innovative. And I'll try to move a little bit quicker on a few other examples. Next slide, where we talk about cancer care. The same thing. And on cancer care, here have been great examples on how we can think about being ambitious, but as again, thinking about partnership that helps incrementally improving that service. When we started the cancer center in Butaro, we already started with that ambition that we want to make sure that patients are able to be diagnosed as early as possible and linked to the treatment that they need as soon as possible. That was our ambition. But how do we build that in a district hospital? How do we link that to the overall system? That have been the work now in terms of implementation research, and how does that work? And how did that happen incrementally? When we started in 2012, we did not have any pathologists. But then the question was, where do we find the skills that we need? What are the level of skills that we need to have our lab technicians at the hospital to have? And how do we link them to the support that they need? So, and through which partnership? So we worked with the American Association of Radiologists to help us getting few equipments of good quality that could serve in a district hospital. So partnership helped us get the stuff. But then we needed to have clinicians being trained. We sent 2 lab technicians to Brigham Women Hospital to be trained for a long period on processing the tissues. But then we're able now, we have equipment to process the tissue. We have the ability to produce slides, but we have no one to read the slides. So how do we build that again? We worked in the same network of hospitals that supported us to identify pathologists in those hospitals that could offer free voluntary time to read the slides for us. But these are pathologists abroad. So we had to put in place a telepathology system where slides could be read by distance and in partnership with our lab technicians. But today, these have been a progress, incremental progress, but today the hospital have actually in place 3 pathologists. So the aim was clear, but how do we get there have been an incremental work through partnership. The same thing with access to chemotherapy and so forth. And as we're implementing that, remember that the second principle in terms of what works, the idea of, okay, we're getting patients here. They are being referred from different places in the country, but the issue that we are facing now, these patients are coming in the hospital, they are staying there with their families for a long period, and we started to have patients and families sometimes sleeping outside. How do we manage that? How do you help to make sure that in the context where we are in a rural place, there's an additional element that is needed to make sure that this care is optimum? You need to have a support center, a hostel that will have them living there, but at the same time providing them with psychological and counseling support. So that's an element which in certain contexts might not be necessary, but the reality for our service to work, that was a necessary element. So always keep a mind open on assessing what works and adding that in your program to make sure that the optimum service is provided. Next. And remember always, we're talking about numbers, and this picture put it here to always remember that when we're talking about numbers, we're talking about people. And they are talking about people with their families, we're talking about people with their dreams, with their hope, and that should be a source of energy to really make sure that we are open-minded, that the moving target, that we chase the moving target, and that we are honest in how we assess what works for these people within their context of life, within what they struggle with, and make sure that we ease the weight for them. Next. Then, talking about chronic care, again, this is another example of moving target. We went a big step ahead as a country to make sure that non-communicable diseases are integrated as priority, systems have been in place, people have been trained, we developed non-communicable disease clinics and the package of service, medicine and essential medicine, list distribution happening, and patients have been coming to care. Then hit a pandemic like COVID, where you need people to get their medicine on a monthly basis, come to the clinic or get tested and to their routine care. How nimble are we as a system? Because when we talk about resilient system and robust system, is one of the quality of a resilient and robust system is nimbleness, how the system is nimble to adapt to situations like this of crisis. And we had an example of this during COVID, where immediately we had to partner with Zipline to make sure that we don't ask the cancer patients who are on oral chemotherapy and who have been stable for years to come to the clinic to get their oral chemotherapy and work on them to deliver the chemotherapy to them through drones and minimize the need to move in a time of COVID pandemic where movement have been reduced as, at the maximum possible. So these have been one approach. Second approach, how do we work with the network of hospitals? We worked closely with the Rwanda Military Hospital to make sure that we shift some package of clinics to have 2 sites where we follow these patients, with patients within the northern west province going to Butaro, people within the South, Central, East province going to Rwanda Military Hospital and developed a transportation network on how we move these patients. And these are patients mainly who needs chemotherapy that cannot be provided, IV chemotherapy that cannot be provided at the district hospital or the health center closer to them. So work closely with multiple sectors to make it happen. And this system was working within 2 weeks of the beginning of the pandemic. Nimbleness of the system, and how have we been innovative in making it happen. Other aspect we are looking into innovation that is not on my slides as I'm getting to the conclusion. I've been thinking in terms of what are the best practices and how much can we incorporate that into care. And here I want to talk about diabetic patients. We all know that diabetic patients need to assess their glucose level almost on a daily basis. But in our clinic processes, because where we work in rural place, we ask patients to come once a month for clinic, and that's when they're getting checked on their glucose level. Is that the optimum service? No. What are the things that are out there we can do? And now some research we hope will be some of our team will talk about in this session or in the future have been the use of glucometer tests by patients themselves at the community where we work. A lot of challenges, but remember the mindset of what works as we're working with these patients until we come to a clear way of making sure that the patient can get their tests as much as possible on a daily basis, and how do we link that to the clinic so that the nurses and the doctors who follow them get the information. So a lot of innovation, again, coming your way soon. But I wanted really to share with you the mindset and the view in the way we work into service delivery, improving service delivery using innovation. Thank you again. I think that was my last slide. Oh, no. Okay. Maybe 3 steps ahead of my slides. But that slide, go back to that, go back to the previous slide, is a summary of what I just talked. How do we keep a focus on service delivery, but how do we link that with research that inform both the teaching, the training, the capacity building, and improve service delivery, and how does service delivery on the other side as well improve research? And that cycle is what I would call a virtuous cycle in improving service delivery using innovation. Thank you very much.
Thank you very much for enlightening us with that presentation, reminding us that all the numbers that we're talking about, they are people, they are faces behind those numbers. There are dreams, and there's hope behind those numbers. And thank you so much, Partners in Health, for ensuring that we could just look around and we find solutions that works. And that is a great example. Where I work from, actually, we've already partnered with Partners in Health to help one of our cancer patients, mainly those that are having gestational trophoblastic diseases and neoplasia, and it's working. So I think experience sharing is what we need from here. Thank you so much, Director General. So now I'd like to ask the tech team to bring our keynote speaker, if possible. She's been listening us from all the way from London, and I'd like to call her if she's here. I'm sure she's listening us, but I want to see her. Please, if you could do that for us. We've been talking about clinical, mainly from the Partners in Health perspective, the clinical aspect of innovations. How do we innovate in a clinical setting, in a hospital, in a health center? But there's more that we can actually talk about. And our keynote speaker is going to talk to us about research, innovations, methods in a public health and environment. Thank you so much. We're joined by Professor Malta. Professor Malta is a professor of biostatistics in the Department of Epidemiology and Biostatistics. And she leads the biostatistics and data science team of the MRC Center of Environment and Health. Her main research interests are related on the methodological aspects of environment exposure, estimation, and on spatial and spatio-temporal models for disease mapping and for risk assessment. Professor Malta holds a master's degree in statistics, demography, and social sciences from the University of Milan in Italy. And she holds a PhD in applied statistics from the University of Florence in Italy. Professor Malta is currently working on different projects. I'll mention a few: air pollution models, air pollution modeling, environment, epidemiology, and climate change. She has published in various research, and she's co-authored in a book on integrated nested leaflet approximation for spatial and spatio-temporal applications. She is here with us in London.
Hello.
Hello. Thank you so much for joining us. The floor is yours.
Thank you so much for having me. It's such a pleasure. I'm just sorry I cannot be there in person. I'll try and share my screen. This one. Okay, can you see my screen? I assume so. Yeah, okay. Okay, so thank you very much. Can you see?
Not yet. Can we have the tech helping us to have the slides up? Thank you. Now we are ready. Yes, you can go ahead.
Good.
Good.
Excellent. So thank you very much. So I was given this title, which is Research Innovation Methods in Public Health and Environment. And I thought I started just saying something about the fact that we have so much data availability over the last decade. Now, the data is basically becoming enormous. And just to give you a few examples, we have, for instance, data on satellites which are used for particularly for environmental stressors, for instance, for temperature, for rainfall, for air pollution. This is a nitrogen dioxide map, which is kind of like all over the world. So it is really great. It is a massive amount of data. Low-cost sensors are also very much used through wearables, for instance, through the phone, the mobiles, so that actually, you could kind of like follow people and get their exposure to a variety of environmental stressors. And then we have seen in the last 2 years with the pandemic, so many different dashboards. This is the WHO one on the number of cases of COVID. This is our world in data, which I've just put here, United Kingdom, United States, and Rwanda. And you can actually obviously see all the cases going up and down throughout the pandemic. Now, it is a challenging opportunity in the sense that it is possible with all this data to now reach places and communities which are more remote, places which we were less able to analyze before. We can also provide quasi-real-time inference. So in a sort of like a public health perspective, with all this data, we are much more capable now of predicting, forecasting in almost like real time. So there is also a very much more direct link with policy. However, this is also very challenging. First of all, because of the amount of data, this is very computationally intensive. So it's sort of like you really need computational resources in order to actually analyze the data. The quality is not necessarily always great. There are biases, there are uncertainties in all this type of data, and then there are structures, for instance, in space or in time, and all this needs to be accounted for. So in this talk, what I want to just give you is an overview of statistical methods to deal with some of these challenges. In particular, I'm just going to give you 2 examples. One which is related to air pollution, and basically trying to disentangle the total particulate matter into sources to try and get a closer link with policy. And the second one is related to COVID, and it was sort of like trying to use spatiotemporal models to look at variables at the community level and see if actually some of these variables could explain the geographical variation in excess mortality which we saw. places like the Arctic, apparently casts some shadows on the ice, and that increases the ice melting. Also, the smog is worsened by increased heat. And air pollution is very much related to the SDG set by WHO, for instance, in the reduction of death and illnesses from air pollution, in the access to clean energy, and in the reduction of the environmental impact of cities by basically improving air quality. We also know that air pollution is really bad for health, and here there are a couple of references. I'm not going to go into that, but you may recall HIARC called air pollution carcinogenic in 2015. We know that about 7 million premature deaths every year are due to air pollution. And there's also synergistic effect between heat and air pollution for all-cause mortality and for cardiorespiratory mortality and hospital admission. So obviously this is really bad for us. Now, what the problem is that obviously when we breed a mixture of pollutants. We're not really breeding one pollutant at a time. And the air pollution is very complex, because here is a picture, is basically a mixture of all these primary particles which are emitted directly, for instance, from the exhaust of the cars, or from industries, or from wood burning, for instance. And then there are secondary particles which are created in the atmosphere because there are links with gases, like here, for instance, with SO2 or VOC. So basically, typically epidemiological studies, what they do is they consider the totality of the particulate matter, so imagine all this, and link it with health outcomes like, for instance, cardiorespiratory, hospital admission, or mortality. However, obviously the same level of particulate matter could actually come from very different sources. So it is very important to try and disentangle these sources so that we actually know, in terms of policy, where we need to act to reduce the particulate matter. And also because some of these sources may be more toxic to health than others. It is a problem, it is a challenging problem. Again, we have lots of data. For instance, here is looking at particle sizes. And you see there is sort of like a lot of correlation. The yellow ones here means that there is a correlation across the particle sizes, which is huge, above 0.97. It's also a big data set. So we have high dimensionality and high correlation. And so we need to use some complex methods to try and deal with this and to make sense of this. So what people have done in the literature is to try and do dimension reduction. So basically starting with all this data and kind of like trying to find some clusters, some groups which resemble sources. And so forget the formulas, I'll just put it here in case there is someone in the audience who is particularly interested. But basically you get the different components of the RPM and you try to go back to these profiles, which are these sources, okay? And for instance, this is an example here on the right. We have, the total PM 2.5 in this case, and then we actually are able through these methods to say that the traffic actually is the major component, the main component for 66% of the total concentration. But there is also biomass burning, there is secondary aerosol, there is industry. And so obviously once we know all that, we can actually try and tackle these sources more specifically. Now, the problem of this approach of factor analysis is that the number of sources you have to decide a priori. So I have to say to the algorithm how many sources I want to find, basically. And we're not really accounting for uncertainty in the allocation. And then we can't really include space-time dependence, okay? So what we can do is actually use some more machine learning methods, more flexible methods, data-driven approaches. And for instance, Bayesian non-parametric methods have been used in this context. Again, don't really look too much on the equation. The idea here is that you actually do not fix the sources a priori, but you're just saying have lots of sources, and then the model through all these equations and through actually the link with covariates, for instance, the link with wind, which is obviously very important in air pollution because, you know, where the wind is blowing, it's gonna blow sort of like particles. So using wind to try and characterize these sources, for instance, is very important. So using that, together with the fact that we are having a very data-driven approach, allows us to find the perfect number of sources, basically. And we did that for to try and find sources around Gatwick Airport, which is one of the London airports in the UK. So we ran this very flexible model, and what we found was that we had 9 sources, which covered all the spectrum of the particle sizes. And then the other very challenging point is you get all this outcome, and then you actually need to interpret this. So basically, these names, we sort of like, we had to find these names, talking with exposure scientists, experts, because actually what you get is just this, you know, 9 profiles. And to interpret what I said before, it's like, it's very important, for instance, to use covariates like the wind. Because what we found, for instance, this is a little map of Gatwick Airport, and this is the monitoring station where we got the information on the pollutant from, which is slightly north of Gatwick. What we found was one source, really big, 25%, 26% of the concentration, with the wind, which comes from the south, okay? From here, basically. So that actually makes us think that this is the component coming from the airport, so the air pollution coming from the planes. On the other hand, we also found another component which was 8%, with wind coming from the north. And north of this, there is London. So we actually thought that that was urban source. And then we also, for instance, found biomass burning, which was about 11%, and then age and fresh traffic, so sort of like loss of traffic as well. So the wind would really help, together with obviously the profiles, and we know that, for instance, you know, in the airport, you expect really tiny particle sizes. So actually this red curve here, it's very, you know, that could really represent the airport, for instance. So all this combination would help us interpret the sources, and then after that, what we want to do is to link this with health outcomes for people in the areas to actually see if we see an association between these sources and the clinical outcomes, basically. So I'm going to move to the next example, which is looking, as I was saying, looking at community level covariates and see if we can explain variation in excess mortality during the COVID pandemic. And excess mortality has been used a lot throughout the pandemic and is defined as the combination of deaths caused or contributed to by the infection, but also deaths which resulted from other, you know, other behavior changes in social and healthcare strategies and, you know, rules. So basically, it's direct and indirect effect of the pandemic. So lots of studies use that, and I've just put 2 here, which are quite big studies looking at country level excess mortality in sort of like in a time series fashion. But so most of the studies looked at national level data, while we think it's very important to also go subnational, because we actually know that the pandemic was not uniform across the territory. So even within a specific country, there were lots of differences. And we want to quantify these differences, and we also want to know, we also want to find if there are characteristics which can explain this variation. If you want some risk factors for excess mortality. So what we did in this context was, as I said, investigate the role of area level covariates to explain the spatial pattern in excess mortality. And we did this in England, Italy, and Sweden. Again, we used quite a flexible spatial model. And we had geocoded data on all the deaths in people over 40 years. And we considered 1 year, so we considered March 2020 to February 2021, and we used a comparison period, which was 2015 to 2019. So the idea is to look at mortality during the first year of the pandemic, compare it with what was in the previous years, and then see if this difference in space actually can be explained by some community level characteristics. Now, because we had 3 countries, we needed to find a consistent geography, which for us was some kind of like province level. And then we also needed to find consistent covariates. And so we wanted to cover areas like deprivation, socioeconomic deprivation, air pollution, living conditions, something like overcrowding, for instance, population density, and then how people move. And then we did the analysis stratified by sex and country for all the ages. So, again, few equations if you're interested in, otherwise don't worry. The first is a 2-stage, so it's basically 2 models, one after the other. In the first one, we estimate the mortality rate for each of these provinces for the comparison period, okay? So we're modeling the number of deaths for each year, for each area, and for each stratum. Remember, the stratum are the age and the sex, basically the combination of age and sex. And what we are putting in this model is a spatial dependence, so we have an effect which allows for correlation in space, we have an effect for age, and we have an effect for time. Very simple. In the second stage, we are taking the results of the first stage, we put it in for estimating the death rates in 2020. And actually what we are interested in is this row 1, which is basically the ratio between the rate in 2020 and in the comparison period. So this actually is a measure of excess mortality. And then we model this as a function, again, of some spatial effect, age effect, but then importantly, what we are putting in are these covariates, okay, so this X. And we include this in quintiles, and we propagate the uncertainty from the first stage into the second one. So I'm just going to quickly show you some results. Here is for England, and these maps show the excess mortality at the top, the mean excess mortality for the entire period, and at the bottom, there is the probability of having an excess mortality which is above 0. So basically, where you see something which is sort of like bluish and dark blue, it means there is a probability higher. So the excess mortality being positive, the probability is higher than the excess mortality being negative, basically. So what we see is actually lots of things going on in the big cities, like here is London, Birmingham, here you have like Manchester, Liverpool, so big cities, okay? And there is some spatial variation, but not so much. For Italy, is actually quite a different picture, because you see the colors is very clustered. So the north was really badly hit, and then some part of the south, but then the remaining of the country was not so badly hit. So there is a lot of local clustering. And Sweden, actually, we don't see any local clustering at all. There is a lot of uncertainty, and actually that was the country where we saw the smallest excess mortality. Now, if we look at actually the covariates, and I'm gonna sort of like switch between the 3 countries. The covariates we included were 2 on air pollution, so nitrogen dioxide and particulate matter, then population density, overcrowding, deprivation, and then this workplace visit gives an idea of people moving, basically. And so what we see, for instance, is in England is we get a big effect of deprivation, something on overcrowding, and a little bit of population density, something on air pollution. If you actually look at Sweden, it is quite similar, except for air pollution, you get population density, overcrowding, and deprivation. Italy is quite different. The only variable which was basically common for all of the 3 countries in the effect of excess mortality is actually socioeconomic deprivation here. Then, for instance, Italy had an effect of air pollution, which we didn't see for the other countries, so strong. And actually population density was sort of like negatively associated. Obviously, these countries are different, so we expect difference. That was one of the things we wanted to, to find out. And it was quite interesting to find that England and Sweden were quite similar, while Italy was sort of like a little bit different. So with this, we basically wanted to claim some national analyses are very important to highlight differences in excess mortality and to try and find if there are local characteristics which explain these differences. This is very important if actually then you want to coordinate intervention strategies, because maybe rather than do national intervention strategies, you really need to focus more on local ones. And the spatial temporal Bayesian models is very flexible. Because it provides estimates which are very stable. We can account for correlation. We can report and model uncertainty. What we want to do in the future is trying to combine the excess mortality with the COVID-specific mortality and see if we then can see differences in the direct and indirect effect of the pandemic. And also see if these community-level characteristics, their impact change, for instance, throughout the pandemic, between the first wave, the second wave, and so on in the different countries. So I think I am going to finish here. These are like some references. I'm happy to share the slides, to send the slides if someone is interested. And here are my contacts if you are interested in contacting me. And yeah, I hope I just gave you a, a little overview of some of the methods that can be used with this large, and over expanding data sets. And maybe some of this could also be interesting for Rwanda. And I think I am done.
Thank you so much, Prof. Can we give her a big round of applause?
Thank you.
I'm sure those are the presentations you listen to and you really, really want to go deeper and deeper and deeper to understand every word. And I think, as she mentioned before, these are scalable results that we can actually also implement here in Rwanda. And I'm sure similar efforts were done by the RBC and the Ministry of Health during the COVID pandemic, because we know whereby solutions and responses to the COVID were taken in accordance to how the characteristics of different environment. So thank you so much, and I am sure in the next session, maybe the people given the audience will be given a chance to ask some questions. So if you don't have, if you have some time, please hang in there. We could get to ask some few questions. Can I have the microphone, the other microphone work? Thank you. It has been a lot of me standing there and you listening and sitting, and I would like to welcome everyone to stand up as we switch to the next session. I'm going to teach you some few tricks to make some calculations. So back then in primary school, we used to get, to learn some few tricks to make some calculations. And here is one of the ones that I used to do. So if we take this as 1, can everyone do with me? 1 plus 1 equals 2. Right? Now, what if we do 2? 2 plus 2 equals 4. We can do it, right? Now let's make it a little bit tricky. So 4 plus 4 equals 8. Thank you. You may be seated. So now that we are more awake and ready, we're going to welcome a panel discussion. And this panel is going to be led by Clarisse Musana-Baganwa, who is currently serving as a medical research analyst at the Rwanda Biomedical Center. And she has more than 10 years of experience in coordination and conducting medical research projects at a national and international level. She is a research associate at the University of South Florida in the US and a next generation scientist at Novartis, Switzerland since 2019. Clarisse is completing her PhD in epigenetics and bioinformatics application in the field of medical neurosciences and biogerontology at Donder's Center for Medical Neuroscience at Radboud University in the Netherlands. In a joint collaboration with also Brussels, Belgium, VUB University, she holds a master's in science in epidemiology from the University of Rwanda and a second master's in international public health from Manchester Metropolitan University in the UK, and a bachelor's of science in biotechnology and biochemistry and genetic engineering from the Bangalore University. She has a postgraduate. She is a postgraduate in bioinformatics and clinical research. She's a PI, principal investigator in many research projects, primarily in cancer, neuropsychiatry disorders, COVID-19, cardiovascular diseases, and infectious disease. She's published and co-authored, and she's published a number of articles in international scientific journals, and she's a reviewer in several scientific journals. That person is not virtual. She's in the room. Let's give a hand of applause to Clarisse as she walks the stage.
Good morning, everyone. Thank you so much, MC, for that introduction. Yeah, so as MC mentioned, we are switching on to the panel discussion, and this discussion will be focusing on promoting innovative practices for better health. We're going to host high-caliber experts and researchers in different domains. As you might have heard, most of them have really accomplished many projects and many outputs that we think you're going to learn from them, how we can continue the journey of promoting innovation and research as we improve the health of our population. So as I call upon our panelists, I would like to introduce some of them, and others have already been introduced in the previous session, so it will be easier for me. So as I start, I would like to invite Dr. Joel Mobiliki to come on to join me on the stage. You can sit anywhere. Yeah. The next, I would like to invite Noela Bigirimana, our Deputy Director General of Rwanda Biomedical Center. Please help me to welcome her on the stage. I would like to briefly introduce the profile of Noela, as she has not been here in the previous session. Noela Bigirimana is the Deputy Director General, as I mentioned, and she previously served as the Division Manager of Research Innovation and Data Science at RBC. She has also served as Precision Medicine Fellow at the World Economic Forum, where she focused on co-designing policy and governance approach to accelerate the adoption of emerging technology in low-resource settings. Noela currently serves on advisory board of Artificial Intelligence Transparency Institute, and also serves as the advisory board chair of the Youth Combating Entities. She's a World Economic Forum's Global Shaper in Kigali Hub, and a contributor at the Future Africa Forum. She holds a bachelor degree in human biology and health and society from Cornell University in the US. She also holds a master's degree in health policy and management from Hela School of Brandeis University. Welcome, Noela. I would also like to allow me to also introduce Dr. Sabin Sanzimana. Please join me to welcome him. I would also like to introduce some of his profiles. Dr. Sabin Sanzimana is the Director General of the University of Teaching Hospital of Butaro, Butare since March 2022. He's a fellow of the African Scientific Institute and of the Royal College of Physicians of Edinburgh. He also serves as assistant professor of global health at the University of Global Health Equity, and he's a lecturer at the University of Rwanda teaching epidemiology and research methodology. Dr. Sabe has worked in the health sector for over 14 years with extensive experience in infectious disease control, research. Prior to his appointment, Dr. Sabe was the Director General of Rwanda Biomedical Center, where he led a number of technical aspects of COVID-19 response and had previously led the national HIV program for over 10 years. He holds a PhD in clinical epidemiology from Basel University, Switzerland. He also holds a master's degree in clinical epidemiology from University of Rwanda. Please join me to welcome Dr. Sabe on board. Then I would like to invite Professor Eugene Mutimura, the Executive Director of National Council of Science and Technology. I think he has already been introduced in the previous session. So please help me to welcome him on the stage. I would also like to invite Professor Martha, who is on virtually, who just presented. She will be contributing in this panel discussion, and she has already been introduced in the previous sessions. So welcome on board. So as we start our discussion, we will be focusing on the promoting innovative practice for better health, as we mentioned. But I would like to pose a question as we are entering a post-pandemic recovery phase for COVID-19. In the journey of unlocking innovations to accelerate building a resilient health system, I would like to hear more, how do you envision science and technology to really tighten our health system to prepare for future pandemic? I will start with Professor Eugene Mutimura to really highlight some key steps and progress of science innovation. Thank you.
Thank you, Carolisa, for moderating the session and also giving us an opportunity to talk about what can we do as leaders, as scientists, as researchers, as clinicians, post-COVID-19 pandemic. In my previous remarks, I talked about how COVID-19 has impacted Rwanda, Africa, and global community. And the impact has been very bad. But it has brought very important lessons. And so we can always cherish and ensure that the responses that have been in place are leveraged to another level. And when we talk about embracing science, technology, innovation, that is the way to go. And so a couple of important messages centered on one important element, building resilience in our health systems strengthening to ensure that we prepare for next challenges related to viral infectious diseases, potential epidemics, and even pandemics. How do we do that? First, we need to consider what we abbreviate it as THIC, meaning technology resources, human resources, infrastructure and collaboration, and then collaboration, knowledge resources to ensure that you have a very good functioning innovation ecosystem in this particular case, health system. Also, we need to have good diagnostics systems. Carissa, you are working on research on rapid diagnostic tests for COVID-19 and potentially other viral infections that can support building resiliency. Technology resources related to infrastructure, also capacity building. So let me try to be brief on that because my colleagues are going to highlight much more information. But finally, as we saw Rwanda's response to COVID-19, a lot was centered on good leadership. Very important, very visionary political leadership that engages the community, local communities, that mobilizes resources in an agile, flexible manner without disregarding elements of good governance and accountability. Mobilizing human resource is critically important to fight COVID-19 pandemic, but also build resiliency in the future. Thank you.
Thank you very much, Professor Eugene. Let me invite Dr. Sabel to also contribute on, as he has been really involved in various research and with his experience in infectious disease control. I would like to hear more about the challenges that you see in the healthcare setting in terms of implementing research. What are the challenges that you see and how can we overcome them in the future?
Great. Thank you, Clarice. Good morning. So maybe before I talk about research challenges, let me speak about the post-recovery, because there are many ways we can see things and define things. I would probably call it post-active phase of this pandemic, because if you look at where we came from and where we are heading, this pandemic is yet to disappear, and the history of other pandemics has been almost the same. They may take another shape and another direction, but still these viruses may not completely disappear. But people have better tools to deal with it, including vaccines. So this is probably one first thing I want to highlight. So in terms of research, we've seen that, especially in our settings, we need to run faster, at least to catch up, to attain the baseline of where other countries in the world are set right now. If we think of the 2% contribution of research from Africa to 98% of research that the rest of the world are contributing, we're really very far from even beginning to try our best. And this symposium brings in some reflections to that. So my work, and I have colleagues, we work together from University Hospital, we probably even far behind than the public health institutions and academic institutions when it comes of the aspect of doing research. If you see the clinical activities and how people are dealing with so many patients every day, clinicians are seeing up to 50 patients a day. And the time to do research, even the exposure, even the practice, even the capabilities to have those statistical context and have statisticians within our hospitals to try to boost this research is something really we need to work on very seriously. We've started, at least in the hospital where I work, to build these capacities, to have statisticians and epidemiologists to help clinicians to bring research at another level, and having this framework to come together, it's another good thing. I think Dr. Jean knows what is in the pipeline. So we look forward to have this integration really maturing and taking another shape from academics, from implementation, but also from this clinical aspect. So I believe we have many challenges, but COVID has shown us that we have the potential to do even better, given the presentation we've seen this morning and what other colleagues have been presenting, that when the flights were not moving, people could do things even better here in lab, what you've been doing yourself, in technology, what the people did in having all these dashboards, the data we've been using, but also in our hospitals, how we can see the trend of diseases and even develop therapeutics and clinical trials. Let me pause there.
Thank you very much, Dr. Sabel. Let me invite also Noela to share her experience in the health system. How do you see implementing institutions like RBC in terms of readiness, research readiness? How do we really implement interventions based on the research output that we get?
So thank you, and I want to first thank everyone for being here. I think day 3 has been quite engaging, and so maybe before I answer that question, to add slightly more context, as Dr. Saban just mentioned, it's not fully that we're in a post-recovery, and I think that's important to note. When you look around the room, of course, none of us are wearing a mask. Maybe I see one person at the back there. But it doesn't mean that the pandemic is over. But if you even take a look at the region and the globe, we're dealing with other crises. So when you hear post-recovery, also keep that, we have to keep that in mind. And so preparedness and response have to remain sort of at the top of the agenda. And so from that perspective, we know that the contribution that research has, right? So I like to say, when you look around the venue like this is one of the most important rooms to be in. We've had time to reflect on what has been done over the past 2 years or even more. We have people that have joined us online, so it's the right context to be reflecting on this. We've seen the role of research in terms of the contribution that research has made in terms of the service delivery. We've seen the contribution in terms of generating the evidence that have actually resulted in some of the tools we use, such as the vaccinations and the therapeutics. We've seen the role that research can have in the context of policy and influencing, so that it's not just a publication, but that it's actually influencing the ultimate outcome that we want, which is the impact on the population. So on your question around the role of an institution like the RBC, I think we have to put it again in the context of we have partners that help us do what we're able to do. The role that we have is that we are able to implement research and research across many diseases, infectious diseases, but also non-communicable diseases and anything in between. We are also able to participate and contribute to other types of research happening elsewhere. And we also are, entrusted with creating the environment to ensure that it is the right kind of research environment. So when you think of what it takes, I want to borrow from what Dr. Joel mentioned earlier, the 5S. It's at least, and let me try to pronounce it, the staff, there's the systems, and the support. So all across those, RBC has a role to play, but it's also within the context of the partnership that we have with academia, the partnership with the development partners, the scientists in the room and online, the NGOs, the private sector, the industry players. When I think of R&D, for example, we've had discussions around vaccine manufacturing, and it's when you think of the spectrum of the research and what it turns into, the product development, we've heard Rwanda's ambitions, and An institution like ours is entrusted with ensuring that the right environment is in place, along with the NCST that has helped us run some of the research, including, I think we've mentioned that you're one of the beneficiaries and PIs of this research. But I look around the room and I see people that have participated in a lot of the work that we do. So although I'm mentioning the role that we have, the importance of research, I want to also pinpoint the role of collaboration, right? And I look forward to working more and more closely with many people in this room, so that we don't approach it necessarily as a post-recovery, but we approach it as like a path into preparedness and increasing like the robustness and readiness of our system. I'll pause here as well.
Thank you very much. Now let me turn to Dr. Joel. We appreciate the contribution of development partners in the journey of building a resilient healthcare system. And we learned a lot on how you are translating the research output into to inform interventions that you are doing in different healthcare settings in Rwanda. So we would like to hear more, what are the challenges as a partner that you see or you face while you're conducting your research, and how do you see government to support you in really streamline the process and remove those barriers?
Thank you very much for that question. Thinking about the challenges that we face when we're implementing some of the researches that we do, as I say, the research that we do happen really within the context of a functioning public health system. So we don't operate or implement the research that we do out of it. It's not a kind of either clinical trial or RCT. It's really happen on how can we implement already existing either policies or already existing things that are proved to be evidence-based, but within the context of where we live. So that itself brings its own complications because you are operating in a place which initially is not primarily designed for that. It's not primarily the human resource, the clinicians, the nurses, the team that are there are not primarily designed for that. So that comes with its own level of complication in terms of engagement to the process, in terms of availability of the right skills, also in terms of adaptation of internal regulations within the facilities to accommodate those levels of work. So what we have been doing to go around those challenges have been to engage even in the capacity building, the interests and the skills of the people we work with directly. I think it has been now probably 10 years that we have been doing what we call operational research trainings, where we work with nurses, clinicians at the hospital, at the health centers, picking their own interests, then supporting them with a team of experts from proposal writing to implementation of their own research to findings and so forth. And I think maybe one additional thing that we'll have to think about adding should be how can we translate some of those findings from the people themselves into policy briefs. I like the idea that was shared from the Ministry of Health. How do we make sure that those findings are actually informing back into the policy? The work that we did was things that are evidence-based, how are they implemented in our context? Or policies that are already in place, how are they functioning and what works? Then the information that comes from there, how does it feed back into the policy? And I think that feedback loop have not always been perfect. And I think that's a challenge that we need to work on. And I think that process and a forum like this is the right place to discuss this and probably have the right people in charge to have more conversation afterward on how do we improve that. The feedback loop between policy in practice, but as well practice in policy. For example, when we say that NCD clinics at the district hospital should be run by nurses and so forth, but in practice, how does that happen? What are the support that they need? what are the blockage that they find, and how can that be informed into policy. I think we did an assessment and found, for example, that though they feel, most of them, very skilled and be able to do certain things like even a heart ultrasound at basic knowledge, but they feel like the credentials or the how do you call it, their professional credential does not give them the boundaries to perform something like that. How can that information be brought back to their professional bodies, the union, and so forth, to make sure that there is a protection that allows the people to implement safely moving forward? So I think those levels of feedback loop and communication that allows the things to move and make sure that the practice is benefiting to the patient to the maximum. That's the challenges that we face. And also, I think I also tackled a bit on how can the government and the partners that implement researchers be really communicating within that feedback loop. I want to also comment a bit, even it was not on the question, about I like what Noella said in terms of, it's not really post-COVID. I think we are in a period where COVID came as a disturber. It really happened in a time where it disturbed all of us and disturbed the way we process our decision making and so forth. But on the other hand, it also created platforms that have helped us making those decisions. I remember when there were a lot of lack of knowledge, for example, around the accuracy of rapid tests. And a lot of partners were willing to provide rapid tests in the country. But how the decision making was quick and nimble enough to make quick tests around a big number of people, around the market, assessing and see the accuracy of it and make the decision of its use across the country. Because there were coordination groups and teams from research to implementation that were sharing information instantly and making decisions instantly and make the things move quickly. So I think those platforms we should find a way to maintain them. We should find a way to keep them active. Because I've been talking about post-active, I think they need to find a way to maintain the active place, not make it as a post-active, to help us not only dealing with things like future pandemic and so forth, but also dealing with other things that are current, moving on in our health system. So I think the lessons there, the biggest challenge we have from post-COVID is how do we make sure that we don't lose attention. We are so eager to go back to normal life. But we should not go also to business as usual in the health system. So I think as we go back to normal life, we need to make sure that how do we keep active some of the lessons that have allowed Rwanda to achieve the success that we had, but make them incorporated now into normal business in the way we deal with care. Thank you.
Thank you very much, Joel. I can note that linking researchers and policymakers is still important, not a topic to really discuss. Yeah. So before I invite the audience to ask questions or make comments, I would like also to invite Martha, if she's still online. Can you hear us, Martha, Professor Martha? If not, maybe let me allow the audience, if you have any question, contribution, feel free to ask our panelists. And you'll be telling your name and where you come from, and then your question. You're welcome.
Thank you. I'm Justin from Rwanda Biomedical Center. I've got two questions, and I'll address myself to Deputy Dej of RBC. As we know that pandemics are not predictable, and that countries need to always be prepared and ready to respond when it occurs. So I'd like to ask if we do have enough stockpile that can allow us to effectively respond to any other pandemic that may come without shaking our health system? That was my question number one. I'll go to my question number two. For the pandemics, don't recognize borders, and we do have so many countries that we do share borders with. So how do you work with them in health information sharing? As we are here in digital solutions, so we must be sharing like health information with our neighboring countries to always be alert. So tell me, how do you sharing information?
Thank you. My name is Karikste Gatari. I'm lecturer at University of Rwanda. My question goes to the Deputy DG of RBC. I believe that digital solutions can apply to both human and veterinary medicine. A few months ago, the cabinet took a decision about One Health system, where human medicine and veterinary medicine can join effort to control, let's say, for example, antibiotic resistance in both human and animals, but also to control major zoonotic diseases. Let's mention, for example, tuberculosis, Rift Valley fever, cysticercosis, brucellosis, and so on. My question is, what is the progress on the ground about this integration so far? And also, which institution is responsible for implementing One Health? Is it the Ministry of Health in general or RBC in particular? Thank you.
Thank you. My name is Nguyendewe Gaston from 114 RBC Ministant. My question goes to Noela. As you have said, the existing system that have been created in this time of pandemic, it has to be strengthened or make it the continuity, because it has been impacted the life of the community, not only in this time of pandemic, but also on the other issues regarding to the health delivery. My question is, as I'm working at the call center 114, we have been receiving the clients or the callers asking the other issues regarding to the health system delivery, how they can get how they can get the services. Most of them, it's like they are asking how the health system of the Rwanda is doing. So the question is, how are you going to make continuity in this area and strengthen as the multidisciplinary approach where we work with the different stakeholders, just like those local leaders, community health workers, and so on, and the other partners. Thank you.
Okay, let's pause here. Maybe we first give the opportunity to respond to some of the questions. And I'm sure even if you posed most of the questions to Noela, I think we have experts here, Dr. Sabin and others, who will be jumping in to really clarify on some of the points. So the first question was asked by Justin from RBC. He's asking that as COVID-19 is not predictable, do we have enough stockpile, or are we prepared to really stand for future pandemics? Do we see the health system to stand and not be disturbed? Yeah.
Thank you. So on that question asked by Justin, maybe you already have some of this information as obviously a staff of RBC, but he's also asking about an important aspect of supply chain. So beyond the stockpile, because the idea is not just piling things, because most of the commodities expire, and so it's about making sure we have enough in stock, but really looking at the whole processes. So COVID-19 really challenged supply chain. You remember initially there were huge issues in terms of getting PPEs because a lot of the countries were keeping them. And I want to say that in terms of as a government institution, what's been done is, the processes of supply chain internally into the country, but also outside of the country are being streamlined. We work very closely with institutions like the Rwanda Medical Supplies, but also partners, because it's one area where collaborators were able to help us in ensuring that we access the supply even in the midst of some of the challenges we had during COVID. An important aspect, it's almost like a follow-up topic to this becomes then for the ones that you need, for the supplies that you need, how do you produce them in the region, in the country? So these are some of the discussions that we're seeing happen, right? So if you need to acquire a product and it's one of a necessity, a more sustainable way is not only to look at the stock and how to get them in country, but how to produce them. So these are the conversations that are happening, and we saw some innovations early on. You remember, and it was under Dr. Saban's leadership, we were early in the response, we worked with Fab Lab. They were producing some parts of the PPEs that we couldn't acquire from elsewhere. We had local manufacturers that stepped up to produce these various commodities. So maybe that's how I would comment on this. So it's an issue, it's a broader issue around supply chain, and it's a conversation around local production.
Thank you, Noella. Dr. Sape, do you have something to add on?
No, I think Noella mentioned it very, very correctly. Maybe to expand a little bit, how are we prepared, not just the supply chain, but also beyond that, tracking the next pathogen? How do we know it early before it spreads everywhere? How do we detect it? Diagnostics. How do we treat those who will be infected? How do we share it? How do we communicate to the community? How do we, build data systems? And how do we do clinical trials to know how this virus is evolving, how therapeutics are working, how next vaccine will be working, variants? This is maybe a wider question that many people are trying to respond to, but it's not that what Rwanda is doing is the same as Taiwan is doing or Argentina is doing. Each country have its own system, depending on the reality on the ground, the people, the virus, even the ecosystem that exists. The One Health element that has been mentioned. I'm sure that Jenny will be happy to speak about it in the research context. So I think we need to see that those 7 elements I just briefly mentioned, not just the supply chain, because what we realized during COVID, as Noella said, is that if you rely on someone else to give you the basic necessity for you to survive, you are insecure. And it happened many times, both in testing, both in vaccines. Exports are stopped at the airport, and the local capacity to the basic you need. It's like the example of if you need you need someone else to give you food to eat. It's not the same as you need someone else to give you a jacket or shoes to wear. At least you secure the food, and then if you don't have shoes, you can walk. But if you don't have food, it's a big problem. That's what the government of Rwanda has been really doing, and thanks to our leadership, because if we can manufacture the basics, the next pathogen or the next virus we can easily handle without harming other systems that Dr. Joel has already highlighted.
Thank you so much for your contribution. Another question which was raised by colleagues was on One Health, as you mentioned. I would like to hear more from Noela about how do we integrate One Health as we progress in controlling pandemics, future pandemics, and who is responsible to implement the policy of One Health.
Thank you very much, and I'll invite Professor Mutimura to comment as well. From the perspective of RBC, it's true that it was passed in the cabinet, and so we have an actually dedicated unit within the RBC that falls under the epidemic surveillance and response, and it's a One Health unit, and it's an intent to show that, you know, a lot of the projects have already started. But to be able to dedicate a staff says to, signals that we are about to not only apply the policy, continue to develop it further and implement it. So we are the implementers. We have a One Health unit within RBC, within the division in RBC. When it comes to the resources and the support, that's why I wanted to invite the Executive Secretary of NCST, because they've been critical in making this integration happen.
Sure. Professor Eugene, please.
Thank you, Noera. That's very encouraging. The principle of One Health is very crucial, and as Noera mentioned, it is good that the Rwanda Biomedical Center has a department focusing on disease surveillance, and it is clear that when we talk about One Health, we are really making sure that we tackle it from a policy perspective, implementation perspective, and a preparedness perspective to prevent infectious diseases that may result into epidemics or even pandemics. And so we are quite aware that many of these viruses will always be endemic, and the level at which they strike the population depends on the resilience of the population and how prepared our populations are. Clearly, viruses are going to mutate from time to time, and they will be endemic. So the very important element about One Health is policy on the government working together with other governments on ensuring that they cherish what we call global health security. And that's critically important. How do you do that? You do that by ensuring that you have an enabling involvement in terms of, for instance, setting up institutions like RBC with a department dedicated to disease surveillance, which actually over time has done a lot, because a good response of COVID-19 was partly because of the preparedness of viral infections and pandemics in terms of diagnostics that was established much earlier at RBC through collaborations with other partners. I'm happy also from a research perspective, RBC is working on that. I know Pacific and other teams are working on diagnostics for COVID-19, viral infections, and also how that can happen in non-humans, in apes. You know, mountain gorillas can be potentially reservoirs for these viruses, and RBC is working on some researches to do some point-of-care diagnosis for SARS. And therefore, the gentleman that asked the question, clearly ask yourself, within this environment, what can you contribute in terms of clinical perspective, contribute towards surveillance of the disease, research, and improving practice as well. Thank you.
Yes, madam.
Just one comment that the other entities in the room, when we talk about One Health, is the RAB, Rwanda Agricultural Board, under the leadership of the Minagri. So these conversations are happening more and more. As you saw in March, there's Rift Valley fever that was declared in Kenya. And so a place like that, you'll see that institutions within the human health work very closely with animal health. And so you start to see more and more of this discussion, and we invite Prof. Calix and the others within the context of research to actually help us to keep gaining more and more evidence. So we are linking at the level of policymakers and implementers, but encouraging the academic institutions to also join into that research.
Thank you very much. And then the last question was for Gaston. He wants to know what is the continuity for, what is the strategy to build continuity of the strategies that we put in place while responding to the COVID-19 pandemic. What are the strategies?
Thank you. So I'll maybe answer briefly Mr. Gaston. And he's asking in the context of the call center, but it's also for the other intervention. So, of course, the call center was very widely used within our response and preparedness phase, even before the very first case. And it was a really important interface with our communities and community members. It was used to report potential cases. It was used for people that had symptoms and wanted to know if it could be potentially the COVID-19, but also other questions around health, around non-health topics. So the importance of this platform makes it so that we want to maintain it and maybe adapt it further. And so one of the discussions we've had under the coordination of the Rwanda Health Communication Center, one of the divisions within RBC, is to say, how do you take the call center and really sort of strengthen it and make it not only permanent, but also expand the scope and sort of the reach of the call center. So we'll definitely benefit from an intervention or an approach that was started within COVID-19, but is about to be expanded to all other health and non-health areas. So just to let you know, so it's being done under RHCC to look at then, what comes next. If there is a next crisis, or, how ready are we to be that interface that received, sometimes it's the first line of response. I remember some of the earlier calls that we made within RBC and realized that this call center was one of the immediate ways of accessing our community members. So we value intervention like these ones. We do have to adapt them, so it's not branded as if it's a COVID call center, but rather a call center that's accessible in many ways, and that's able to answer many questions and point our community members to the right type of information and highlight the right type of programs.
Thank you very much. Dr. Joel, do you have something to add before we take 2 more questions and then we conclude?
Yeah, I would like to make a comment on an aspect that I think, at least in the morning, we did not talk a lot when it comes from lesson from COVID that we need to bring forward. I think is we talked about the feedback loop between researcher, policymaker, and so forth, but there's another layer of communication which is with the community. And there, I think there is a lot of work as well to do. I think with COVID, we realized the importance of not only reassuring the community, but also making sure that they don't, they realize what is required from them in managing this pandemic. And that requires specific skill. It requires on how you message that, it requires on how often you share the message and so forth. So I think the lesson learned there should really be built also in other aspects of research to really make sure that we are accompanying the community in the growth of knowledge that we are acquiring as institutions. I think that's an element that we need to strengthen, again, moving forward. COVID pushed that to that point. I remember, if you allow me to share that, Dr. Sabin, when the pandemic was starting and Rwanda was looking at how to bring back some people who have been living in places where there have been pandemic and so forth, and looking at where do we put them in quarantine, where do they spend time and so forth. And wherever you go to a place, okay, we want to bring people, they are not sick, but we need to keep them here. And you say, well, as soon as you mention COVID, people will say, no. There's no way. But we move from there to home-based care. And I think all of that have been how people get the accurate information. And on that also, there is the big challenge of the way communication now happens in this era with social media and so forth. So how to counteract that as well. I think those are an aspect really of research finding and how is it implemented, linking it to the broader community that does not share the same level of knowledge and exposure like most of the people here in this room. It's an important element that I wanted to comment on. Thank you.
Thank you very much. Let me take 2 more questions and then we take another round, then we close.
Thank you. My name is Berison Rugizangoga. I'm a pathologist working at the University of Rwanda and the University Teaching Hospital of Kigali. My question goes to the Executive Director of NCST. And my question also is in line with what the DG of SASHIB has said, that clinical research somehow lags behind research in epidemiology and social medicine in our context or settings. And to my observation also, research in basic sciences is lagging far behind, or there's other strata. So my question is, what are the national strategies to make sure that all these strata are supported as equally as possible? Thank you.
Thank you so much. I'm Victor, a medical doctor working with Swiss Tropical and Public Health Institute. My question is about the strategy we are using to seal research and the policy gap. Talking about how the situation is in terms of education, there are sometimes we get hard time to find local references. And my question is like, what are the strategy for dissemination of the local findings? Because sometimes we find that it's difficult to access them. And in that strategy about, I would like to know if there is any plan of involving academic institutions. And because some of the local findings as other international studies, it's hard to find them if you don't have those kind of subscription in some of the paid journals. So I would like to understand the plan in integrating this process in academic institution, as it's one of the tools for sustainability of this initiative, and we also encourage the project-based learning in our academic institutions. Thank you.
Thank you very much. Let me invite Professor Eugene to help respond on what are the strategies that are in place to boost basic sciences research and their outputs in the country, as they are lagging behind compared to other research areas.
Thank you. That's an important question. So nationally we have what we call National Research Innovation Agenda that provides 6 major priorities in terms of research areas that has to be prioritized. It is true that as a country, you have a lot of priorities. And so you want to narrow down to have specific areas that you can support, that you think are priorities in order to move forward faster. But it doesn't mean that you are not going to support other areas. Let me say that health sector is one of the 6 priority areas, including energy, agriculture, ICT, resilient environment and climate change, local manufacturing and value addition and others. And so what the country is doing in terms of supporting health sector, particularly basic research, is to prioritize it, fund it, and support researchers to ensure that they do research, but also put their funding mechanisms that support them to ensure that they attain results that impact on the lives of Rwandans. Secondly, you certainly know that there have been a lot of opportunities that the government of Rwanda has put in place, which I call actually a unique investment to ensure that research flourishes and improves to another level. You know, several centers of excellences as institutions, but also centers of excellence at the University of Rwanda are in place. That means that you have resources, you have laboratories, you have human resource capacity that has to prevent brain drain, instead have brain saturation, and ensure that research grows. And so out of over, I think, 90 projects that we are funding currently, as I said in my previous remarks, we are funding 30% related to health research. And so it is a clear priority, and actually it is one of the areas that is doing very well in terms of moving research forward. I agree with one of the questions. Dissemination is very important. You need to have results, but these results have to be consumed. So implementation science has to be very, very important. I think Dr. Joel talked about the community engagement. Do not keep your results somewhere without ensuring that the community, who are actually taxpayers, benefit from the results. So these results have to be consumed in terms of health policies, and informed policy and practice. That's critically important. Thank you.
Thank you very much, Professor Jean. Professor Dr. Sabe, can you add on that, please?
Thank you. I want to add just something, because I raised this concern after 2.5 months working in Sashibe. We realized this as a gap, but also an opportunity. The opportunity is that the data that is present in our hospitals is actually precious, and we can take the advantage of having this information, this like patient data that has been captured over decades, but not used to make decisions as it could be. And to me, it's a low-hanging fruit. Something can easily transform into good science with less investment from NCST like priorities and push. So maybe just a real example of something we are doing with Dr. Gilles, who is here in the room, our head of research. So 2 months ago, we started a partnership with Annabelle, thanks to Annabelle, to see what we can do in maternal and child and neonatal department using the available data, and ask the questions that why our mothers are dying, why children are dying in our hospital. Is it because we have done everything, or is it because there are things we are not doing at maximum that is in our hands? So that is a question we asked ourselves. Then we went into our data. Is it because of referral systems? Is it because the flow of patients within the hospital is probably not optimal? Or is it because there's some infections or pathogens that are moving in during within the wards or consultation rooms that we should detect or see the trends? Or because C-sections are not appropriately conducted? So we came up with 14 research projects recently approved in our ethics committee. So we are the phase of data analysis and collection, but we're organizing the data in a way that statistically, methodologically is correct, and it's a win-win situation, because we answer the question we asked ourselves, but also our residents, our interns, our nurses, our midwives are going also to benefit from this research process and even publish and then upgrade their levels from junior consultant to consultant and so on. So this is the first phase of what we can do now with very little resources, just 1 or 2 people coming and help to organize these informations. So we're planning to do it in other departments, surgery, dental, nutrition, lab. So we'll see what we can share with other hospitals. Maybe this is a real example of what is happening. And I think if we come to NCST for some little financial support to these doctors, I think will be welcomed. So any other partner who want to come and work with us, Karibu Tare.
Thank you very much, Dr. Saber. This is a good example, and thank you for sharing the good practices that you have. We hope to visit you and start really engaging at national level. While you're talking about how we can grab NCST to fund some of those initiatives, I had also the same questions to Professor Eugene. We learned that in some of the developed countries, they have dedicated funding for those basic research without passing into competitive stages. Do you see this as something that you can adopt as NCST to really also prioritize those initiatives that are really important, are taken as priorities in the health sector?
The answer is yes. And what we do usually, we ensure that specific sectors indicate clear challenges that are affecting the sector. It could be agriculture, it could be manufacturing made in Rwanda, it could be health sector. You develop a concept note. That concept note has to be approved by your line institution, the leader of your institution, your ministry, and then you give it to us. Mm-hmm. When you give it to us, we table it to our board, and usually our board will expedite it, and then we request for funding. This is usually what we do. But traditionally, we want to be transparent so that the research that is funded goes through a competitive process, peer review process, so that if you apply for research, at least your project has to be reviewed by 3 people independently, and you are scored qualitatively and quantitatively. One of the reviewers should be at least outside Rwanda and should be a renowned expert in the area. Mm-hmm. So that is usually the process, but we can always expedite some processes to fund you. Thank you.
Great news to all of us. Yeah, so as we conclude, Professor Eugene, can you maybe say 2 more words to the audience? Maybe you give advice to students, young researchers who want to shape their careers in research or education, how they can go about that.
Thank you. 2 important things. If you are a student, a clinician, a healthcare professional, here attending this symposium and you want to advance your research career, your clinical practice that is based on research, I should say 2 important things. 1, ask yourself, what can you contribute to your country, Rwanda, in terms of improving the quality of lives for Rwandans? 2, how can I benefit from enormous opportunities that the country has provided to me in order to grow professionally? And based on that, those 2 questions, you want to break them down into something that you can manage. 1, must have a vision. I am a student, I am a clinician, maybe I have not finished my education. You want to have a vision and set up a plan. After 2 years, what shall I do? What will I be able to accomplish? Maybe complete your studies, maybe internship. And then after internship, practice. Within practice, what will you achieve? You want to come up with some publication to have a track record and so forth and so on. Secondly, you want to ensure that you identify professionals who have done very well in the field so that you benchmark your work to what they are doing. A kind of role model. And based on that, they will help you grow professionally. And that's very important. And finally, anticipate challenges, because challenges are best teachers. When you meet challenges, you always work hard to overcome challenges. You will overcome these challenges, and then challenges will help you to learn and improve your career growth. Thank you.
Perfect. Thank you very much, Professor Eugene. Dr. Saber, do you have 2 words that you can inform the healthcare providers who are here and researchers in terms of, as we are now trying to sustain the gains for the healthcare system, our healthcare systems, and as we are preparing also for future pandemics, how do you see us to really set the stage and not lose the momentum for other programs?
Sure. Thank you. I think first message is for all of us. That's my reflection. We probably talk more research than we do research. We should shift to what can we do in practical ways, starting small, fail and keep moving, try again. And research is not equals to funding. Sometimes you may wait until money is coming, and that if the money is not coming, research is not done. So I believe that research is not equal to funding, but research can attract funding to do even more and more research. Research is more partnership, and is more curiosity of asking questions that will change the thing you see is not correct, is not normal, is not clear, and you ask ourselves, what can I do to change this thing? What does it take? And it can start from first-year medical student to PhD or postdoc, or even very senior professor. Small questions or big questions, it doesn't matter. The most important thing is the problem you are solving to the people around you or to the community at the end. For the pandemic preparedness, I think if we take the lessons we already had for the last 2.5 years, it's already enough to make a good progress and even be stronger and ready for any future threat or pressure. Because we've had enough, we've struggled enough, we've built ourselves and our systems, our tools, our leadership has been tremendous. People have been exposed from second year, third year of medicine into epidemiology equally to most senior experts. So this was a very good training opportunity for the ground team, but also for research. And if we continue this way, we can be much more prepared for any threat that is beyond COVID-19. I don't wish that to come, but I don't have guarantee that COVID is the last virus. But I'm glad we're talking about it now, and we shall keep this trend. My last one is for fellows or colleagues who are here working in hospitals, in clinics. The solution is within our hands. So using our own data, we can save so many lives. And it's not going to come from really behind your hospital. It's within your hands if we just ask and interrogate ourselves. What can I do better today than yesterday, tomorrow than today? Thank you.
Thank you very much, Dr. Saba. I would like to also invite you to share with the audience the key innovations that you think might be of priority to accelerate R&D, research and development, as we build a resilient healthcare system for future pandemic. Yeah.
Thank you, Clarisse. It's tough. That would relaunch a whole other conversation. Yeah. But maybe I can just take a few bullet points to conclude. Just almost, I would build on what Dr. Saban just mentioned. To challenge ourselves. We just spent, we're now, still on day 3, and there are sessions that we've attended, and so how is it going to look like when we go back to our places of work on Monday? Let's not leave these best practices that we've heard, these challenges that have been highlighted. I mean, this platform has been quite unique in getting not only evidence from within the country. It's an opportunity to reflect after 2.5 years of crisis mode. It's quite unique. So first will be a challenge to us all. What are we going to take? Let's not leave these points in our minds or in our notebook or in our phones. For some, I know for me, I have so many of these notebooks with me as many conferences that we attend, but the lessons that we're getting from this has to impact our work. So that's the first challenge. And then the second thing is to use this platform and actually document some of this, document officially some of this, right? It's a health research and policy. We've talked about the feedback loop. How is this generation of evidence impacting our work? It doesn't require much resource. Some of it can be adapted immediately. We've heard some examples. Other project may take time, but require intentionality. So encouraging, I know some of us in the room, we know each other as collaborators, but encouraging each and everyone to make more contacts from this room, because I think it's the last two words on this banner, for better health, and we have to get there. That's the outcome. So just wanted to finish with that challenge. What are we taking from this? I hope as conference organizers we will document the learnings, and we still have some important sessions as we conclude day 3, but just that challenge, and individually from wherever we're coming from, and glad to see that there is a strong representation from partners that are coming from outside the country, because whatever we're doing is not in a vacuum, has to be done at the regional and hopefully global stage.
Thank you very much, Dr. Joel. Just a few words on how do you see partners in closing the gaps that we are still observing in healthcare infrastructure, especially in research and development, and how do you see partners to join the efforts with the government to close that loop?
Thank you very much. My final words in that regard will be really an encouragement to consider and prioritize the practice of implementation science or implementation research. And by doing so, I'll go back to one of the questions that I raised in my presentation, to also tailor that effort toward asking the question of what, in this implementation, what works for the most vulnerable. I think, what may work in implementation in a facility like King Faisal will be different with what will work in another setting, in a district hospital or so forth. So, or even in terms of community interventions, what will work in certain community will not work to another. So I think as we tailor the implementation research of the question really to keep a focus on the most vulnerable, I believe it will actually cater for the well-off, but at the same time, it will be an extra effort to really understand the specific challenge a group of people faces. For example, if I take the idea of what is happening at CHUB, it will be interesting to look at as the challenges that the patients who can be considered as poor or whatever faces is the same that other patients face. And there, I think there is a lot of opportunity to innovate. By the way, I would say innovating there is quite easy because you don't need a genetic lab, you don't need, it will always, most of the time, go back around social services, but as well as how do you practice specifically for that group of population. So there's a lot of innovation there. And I think the more partners engage with that lens, the more policy will be informed also with that group of the population within the changes that need to happen. The second point that I would add, you did not ask that question, but I think I wanted to conclude a bit on the idea of of our aspiration to be a moving target. I think that flexibility of anticipating opportunities, anticipating future challenges, and moving our target and in how we build our system should be I don't know how to make it, but should be my advice, my recommendation should be a culture, if I can put it that way. There's a lot of that is coming along the line. We can see now with COVID, no one thought at some point that we'll be pushing to have vaccine manufacturing in the region, but now it's becoming a reality. A lot of pharmaceutical companies now are going toward the idea of providing their patent drugs in low-income countries without the profit margin. Is that an opportunity to see what would that impact in our policies and the system in the supply chain and so forth, and have that anticipation as a moving target? Thank you.
Thank you very much, Dr. Joel. So as a take-home message from our panelists and leaders, first thing is we are going to consider translation of research findings as a priority by really encouraging development of policy briefs and inform our policies. Second, engagement of partners is very important as we progress in building healthcare system. Strengthening diagnostic capabilities as we forecast to track future pathogens which are coming in. Strengthening communication in how the social medias are reacting on different circumstances that are coming in. Clinical trial therapeutics should be a priority for the next preparedness. Manufacturing is key, plant manufacturing and other innovations that will help us to build a sustainable healthcare systems. We also need to learn to document starting from this platform health research symposium, we should document use of data is very key. Networking to keep the momentum of the gains which have been made. Innovation will continue. We don't need to wait for sophisticated infrastructures. We can do innovation wherever we are. Practice of implementation sciences, focusing on vulnerable population would be a key to sustain what we have. And then flexibility for anticipated future opportunities and future challenges. I want you to help me to congratulate and thank our panelists. I think they really did a great job. Thank you very much. I would hand over to MC to continue the program. Thank you.
Another big hand of applause for the moderator and this panel. I think everyone actually took their notes from here. We have this culture, I'm sorry to say, and some of the time when we want to change things, we need to name them. We have a culture whereby people want to get, when it comes to funding for research or grants, people want to get shortcuts. But what I learned from this panel is that there's due process that we should all take to get something. And if we need to get changes, we need really to respect that and get work done. There are no shortcuts in research. Thank you so much. So with the same tone, without going any further, there are no shortcuts in research. And students are here to say that they also need a space. So in the same line, we have students that are pitching their ideas for research and actually for an award. And we're going to request Dr. Orol Nishimwe, a lecturer for health informatics at the College of Medicine and Health Sciences, who has a master's or holds a master's of science in health informatics and a PhD in e-health implementation research, who is also co-chairing and co-principal investigator in some digital health researches. She's the one who is going to help us moderate a next session where students are going to showcase of their ability to actually do research. Let's appreciate her as she takes the stage, and let's have the student come forward if they are fair to also be easy to present. Thank you so much.
Thank you, moderator, for the introduction. Good morning. I am pleased to moderate this session about the 3-minute thesis presentation for our students. Actually, this is a competition, and the competition aims at promoting students' innovative research projects. So we are trying to have a platform for our young researchers so that they can present their research, but also have the space to connect and interact with senior researchers and build scientific networks and collaboration for future research. But in this particular competition, we are also more interested in how our students can, of course they can, confidently present their researches in just 3 minutes, pitching their research ideas and discussing some of the results for their research as they grow in the research career. So we have a group of 5 students competing for the available awards, and we also have a team of assessors who are going to be scoring them as they present their research to us. And as we get set, I would like to invite our first presenter, who is a final year medical student at the University of Rwanda College of Medicine and Health Sciences. This is Mr. Eric, and he will be presenting his research about exploring factors associated with research involvement of undergraduate students at the College of Medicine and Health Sciences, University of Rwanda. So, Mr. Eric, you are welcome, and please be reminded that you only have 3 minutes for presentation, and then another more 3 minutes for the Q&A session. Thank you.
Thank you very much for this wonderful opportunity to present you my research about involvement of undergraduate students of University of Rwanda, specifically College of Medicine and Health Sciences. So I'm Eric Mugabo, as they said, and welcome to my presentation. Early involvement of medical students or students in research is a very important step in professional development, and it tremendously contributes to academic output of the university in question. But unfortunately, previous studies and data show that undergraduate students are not significantly represented in the academic output, and not much data in Sub-Saharan Africa is available about this question. That's why we do our study, to study the level of involvement of students at URA in research, and even study more about the factors that are associated with the research involvement. We did this using a cross-sectional study that covered 3 campuses of URA that host College of Medicine and Health Sciences, and we did use convenient sampling to get the participants. So we used WhatsApp group as the most commonly accessible platform for students. We used Strata for data analysis. We did descriptive statistics and Fisher exact test to analyze our data. We get participants of 324 students who participated in the study, and the tremendously well impressed by their interest in research because around 60% of them said that the importance of undergraduate student research involvement was ranked around 10 out of 10, and around half of the students said that they are interested to take a part in research at the undergraduate level, was around also 10 out of 10. We also assessed their barriers that hinder our students to get involved in research, and inadequate knowledge about research process was the most potent barrier, and followed by lack or shortage of mentors. We did study what students think should be done for strengthening or motivating the experience in research, and the students suggest that we should breed a specific undergrad research center for them to support their work. So this is a graph shows the barriers, and unfortunately, most of some students report that they think they cannot do research at their level. So research students, like students at CMHS, are very interested in research, but they still have limited knowledge, and we recommend that we can establish that center to help them motivate their research, and this will guide improvements in healthcare, and we close the gap in research and health outcomes in Rwanda. Thank you very much.
Thank you so much, Eric. You've just used 2 minutes and 48 seconds. That's great. So now we are moving to the session of Q&A, question and answers. So if in the audience we have someone with a question to Eric, please. We take at least 2 questions. It might be even a comment or not only a question. We have someone here.
Thank you for the good presentation. Actually, I want you, in summary, what are your major findings? If you can give at least 3 major findings, and what do you think out of your finding will benefit our students at University of Rwanda, how they will be fully involved in the research so that they can do something that will develop themselves as well as the country.
Okay.
Wait, do we have another question? Yes.
Thank you. I'm Jean Damour. I'm a medical student. I had like a recommendation and a question. We have developed a program for research mentorship and training program responding to the challenges that you have found in this study. I want to ask you a question. What do you anticipate to be the challenge of developing that support center? What are the challenges and what do you think would be the solutions to address it?
Thank you, Eric. Please go ahead.
Okay, thank you for the good questions. Addressing the first question, that is about the major findings. What we have found exactly is that the research interest of undergraduate students is very high, but they don't know what research is. They are not involved. There are no events, there are no workshops, there are no trainings. Like modules of research are not enough to expose them on what is research and activate their interests. So what can be beneficial to them, as also they reported in our findings, is to establish this undergraduate research support center that can guide or provide research opportunities to students, that can coordinate mentorship between faculty members and students to have them experience in research. This also can organize competitions for undergraduate students. It can provide grants. We have seniors here, but very few grants, maybe even none grants are available for undergraduate students. So if you have this center, will very well address this issue of exposing students to research.
Also, quickly going into the impact of your research on the research at the university. Quickly, 1 more minute for your Q&A.
Okay, thank you very much. This study is very impactful and will help a lot because the university and the decision makers can use it to design more programs to strengthen the experience of undergraduate students in research.
And then 1 sentence for the second question.
The second question, I said that it is still challenging, but we are very happy for this session. We have seen that the budget for research in the national budget has been increased, and we have our mentors here, and
decision makers for the university. So it should be very easy for us now to move forward with strengthening research involvement for students. Thank you.
Thank you, Eric. Help me to appreciate Eric for his presentation. Our second presenter will be Ghislaine Mutatineza. She is a third year medical student at the University of Global Health Equity, and she will be presenting about assessing stress level among medical students in Rwanda. Ghislaine, you are welcome.
Thank you. If we can have our slides projected. Thank you. Next slide. My name is Ghislaine Mutatineza, and it's an honor for me to present to you all my thesis entitled Assessing Stress Level Among Medical Students in Rwanda, a research I did together with Libere Kubwimana, Lahatesi, under supervision of Dr. Rex. Next, we know that medical programs impose high academic pressures on students, and this may be due to some lack of financial resources, also intense academic and clinical workload, and lack of leisure time in their curriculum. And though some stress enhances learning and is needed, but also excessive stress brings mental and physical health problems and can affect their personal or academic or professional level. And in other studies, it has been documented that 26% to 75% of medical students suffered from some levels of stress, of emotion, and some levels of emotional disturbances or disorders due to stress. Next, and in our research, the objective was to assess the stress level among medical students in Rwanda to design culture-appropriate interventions, since the stresses are culture-specific. And we did this research among Rwandan medical schools which were active in 2020-2021 year, and we did a cross-sectional online survey based on the stress and academic life scale. Next. This is how our survey looked like. And we have assessed 7 domains, which are social support, curriculum, and teaching, also academic ambition, self-confidence, anxiety, and performance in emotional financial stability. And next, again, it was categorized into 3 categories, where 0 to 1 was minimal to fairly stressed, and 1.01 to 3 fair to very stressed, and 2.1 to 3 very to severely stressful. And in our findings, we had a sample of 137 participants with the following demographics. And on the next slide, we have a median score of 1.23, and have seen that this falls into the category of fairly to very stressful. And curriculum and teaching was the most source of stress, followed by motivation and self-confidence. And after seeing that medical students face stress, next slide. And also, before again, we had one question that had a comment from the participants that lack of financial support, lack of support from instructors, and disorganized academic activities are also a source of the stress. And as recommendations, we give that there should be curriculum revision, enhancing teaching and learning methodology, also improve students' physical and psychological well-being, and provide mental health services to the students in order to make sure that our future healthcare providers are well-trained in enabling environments. Thank you.
Great. Thank you, Ghislaine, for keeping time as well. You've used 2 minutes and 51 seconds. And now we go into your Q&A session. Do we have questions for Ghislaine? Please.
Maybe as having the microphone, my name is Magnifique, and I'd like to ask you, my first question is, one, you said that curriculum review would be one of your recommendations. So how is curriculum going to solve a question of stress? Second, the issue of stress talks about a person. So you've used a cross-sectional study with a sort of a standardized questionnaire. Are you considering now trying to move to a qualitative study where you're going to actually talk to people and get their perception about how stressful they can be? Thank you.
These are 2 questions already. Let's have Ghislaine respond to those.
Yeah, thank you very much. Curriculum revision was one of the recommendations as the solvers of stress in medical students. And what we suggest that could be done or included in curriculum revision include intense academic and clinical workload for the medical students is the one that brings that stress. And if we include recreation activities in the curriculum, since we saw that lack of recreation activities that could maybe relieve that stress is one of the things that medical students would appreciate. If we include recreation activities that also help them relax or free their mind from that stress, that would be a great thing to do. And for the second question of doing a qualitative study and hear more about what the students say themselves, yes, we could do that, and it was one of our limitations in this study because we conducted this study during the COVID era and we weren't able to reach students specifically and ask them and hear what their comments are. And since now things are easy with movements and communication, qualitative study can be done. Thank you.
Great. We still have one and a half minutes for Ghislaine for questions. Do we have? Yes.
Thank you, Ghislaine. My name is Prosper Karame. I'm from RBC. So my question is, I saw you used one of the tools to assess the stress levels, and I was interested to know whether or not you have looked at the self-inflicted stress triggers, because some of them are not quite addressed, and they vary in different academic media and the environment. So have you looked at that, or do you have planned to involve that or to integrate that for further maybe information about stress levels in academic institutions? Thank you.
Sorry a bit. May you repeat this, the last part after self-triggered stress factors?
So student self-inflicted stress triggers. Let's say you have opportunity maybe to be stress-free, but maybe they don't contribute or adopt such practices. So that's something on the management of their lifestyle or how they actually adhere to the recommendations to reduce stress levels. And in our settings, it has been reported that maybe they don't try to be as flexible as possible to reduce their stress level, and they are always on claiming that the curriculum doesn't fit. So have you assessed that? Thank you.
Yes, thank you. We can say that there might be some self-inflicted stress factors, but also we must consider that medical school is something that when medical students join is some new aspect of their life, and maybe that they're not given enough guidance or mentorship on how to view some aspects of the medical curriculum. Maybe the medical curriculum is, yes, stressful, and we can attribute that some stresses is from the students themselves, but also if guidance and proper mentorship is provided to them, I agree that, I believe that they'll also be able to tackle that self-inflicted stress factors. Thank you.
Thank you. Thank you, Ghislaine. A round of applause for Ghislaine. And then our third presenter will be Mr. Valens. Valens is a final year student in the Department of Environmental Health Sciences. This is in the School of Public Health, College of Medicine and Health Sciences at the University of Rwanda. And he will be presenting his research about knowledge and practices of nurses toward indoor air quality and its implication on pregnancy outcome in Rwanda. Valens, you are welcome.
Thank you. Air pollution has become a global concern, and it is also an important Thank you. Air pollution has become a global concern, and it is also an important environmental factors that affecting the pregnancy outcomes, such as low birth weight, preterm birth, and also the death. WHO reported that 41% of world population are exposed to household air pollution, and also 90% of Rwandan households are still using charcoals and firewood for cooking. This makes the woman more exposed because they are the ones who are doing cooking activities most. Pregnant women are more vulnerable due to their physiological changes of their body during the pregnancy. This can increase the risk of getting low birth weight and preterm birth as an outcomes. Our study aims to access the knowledge and practices of the nurses toward indoor air pollution and its adverse effect on the pregnancy. Focuses on the nurse because the nurses are the ones who provide antenatal care services. This is the services in which the pregnant women are given the health education in order to avoid the poor pregnancy outcomes. After collecting data from 5 health centers selected in Nyamagabe district, we find that among 44 nurses, only 5 are the one who has high level of knowledge on the indoor quality and its impact on the pregnancy, while others are on the low level based on the score they got. On the practices, we observed on the ESA books. These are the books used in antenatal visit, contains different topics to be taught during antenatal visits. And that we find that all health centers has those books. Unfortunately, there is no one containing the topics related to indoor air pollution and its impact on the pregnancy. As the gap was identified in those health centers, we have some recommendation on the Ministry of Health and its partners on its policy making can add those impact. Thank you for your listening.
Thank you so much, Valence. You've also kept the time, 2 minutes, 53 seconds. That's great. So do we have questions for Valence? Questions, comments?
Thank you. I have a question. Why did you take the nurses, not the midwives? Maybe, I think, during the antenatal care, there can be the intervention of the midwives.
Okay, one more question for Valence. Yes.
Thank you so much, Valence, for a good presentation. My question is about more of clarification. I would like to know if you consider like level of education of some of the mothers, because it also sometimes imply the way they take the information from the health facility and more of the adaptability or acceptability of the services.
Thank you. My name is Fabrice Ratukunda from University of Rwanda. I have a comment on the topic. First of all, I would like to thank the presenter for making us aware that indoor air can cause that problem. And I would also congratulate him for giving us such recommendation in improving the indoor air and increasing awareness among the nurses and the midwives. And I would also like to ask for others if there is another comment, some researches they can do, because most of people don't know that there is any problem with indoor air on pregnant women, so that they increase even awareness, not only in Nyamagabe, but also in other districts. Thank you.
Thank you. Valence, 1 minute for the responses.
Thank you for the first question asked about the nurses. It's not also the nurses we are looking at, because as you know, on the health centers, nurses or midwife, they are shifting in their services. All are included, but on the health centers, big numbers are the nurses, because on the health centers, I think there is one only midwife. For the third one, for the further researches done on this, maybe it's the facing or the limitation that we face in this research, because there is efficient resources on these topics. We find that only the Rwandan Demographic Health Survey is the one that have the recent data, and its data also, it's limited to the province levels. No district data or the cells, it's only limited on the province level. I can apologize for the second question. I don't understand if it can repeat.
No, we don't have more time. Maybe you will interact more in the break time. Thank you. A round of applause for Valence. Our fourth speaker will be Samuel Nahimana, who is a final year postgraduate student in the Masters of Data Science and specializing in biostatistics at the African Center of Excellence in Data Science, which is hosted at the University of Rwanda. So Samuel will be talking about detection of pneumonia by chest X-ray using machine learning techniques. Samuel, you are welcome.
Thank you. We can have slide. My project, as I said, is detection of pneumonia by chest X-ray using machine learning techniques. I'd like to have, yes. Pneumonia is a problem that can affect the life of people, and it contributes a lot to the death of children. And in Rwanda, there is a problem of radiologists, so radiology X-ray is considered as the gold standard to diagnose pneumonia. So to solve this problem of low number and death, so we try to develop a system by using a machine learning techniques called convolutional network. Can you go to the next slide? As you see, this is a system, it is called DESNet 201 model. We used to train the image. We had like 5,200 image trained. We trained to be able to differentiate pneumonia and health image. So we can go to the next slide. So this was the result. We were able to detect pneumonia, differentiate it with the test accuracy of 94.39% and precision of 94 and recall of 97. So as we have tried to set aside some 600 images so that we can compare with our system and the radiology system. So as you see, we can be able to, we're able to, among like those who have pneumonia, the radiologists confirm they have pneumonia, we're able to detect 379, and we failed only on 11. And also as you see, we can also have, as you see the image, that is how we're able to detect whether there is a pneumonia on the chest image. So go to the last slide. At the conclusion, the model can detect approximately 96 out of 100 patients. So this is very useful. It can also help to speed up the medical diagnosis and reduce diagnosis time, which can also reduce the death rate. So this can transform the traditional way of medicine to technology. We recommend the hospital to adopt this system. Thank you.
Thank you so much, Samuel, for also keeping time, 2 minutes 41 seconds. Great. So do we have questions for Samuel?
Yes. My name is Magnifique. My question is, with your test, we don't see the false positives that were able to come up with this model. How many patients would actually be called to have pneumonia when they don't have pneumonia? Or how many patients would not have pneumonia and the machine tells that they have pneumonia? If that is there, if we see the specificity and sensitivity of the test, then we can recommend about adoption. Thank you.
Yeah.
Thank you. One more question for, yes, that side.
Thank you very
yes.
much. I wanted to ask, how did you account for the severity of pneumonia when developing your model? Thanks.
Okay, thank you so much, Amos. Simply, I need details about the precision you've used. Thank you.
3 questions for you, Samuel.
Thank you. We can go to the slide on the result. So all of the questions could be answered on. Yes, as this confusion matrix table shows, we had been able to detect very well 210 that are normal, and we failed on 24, only 24 cases. And also we're able to detect 379, and only failed on 11. Those who were normal and who had pneumonia, but the system failed were only 11. So that's answering the false positive and so other question of severity, for me, I'm not a radiologist, so I used only the trend image, only the image, so that we can go to teach the machine to do it. So, yeah, thank you.
Precision?
Precision, it was in the result, so we had a few seconds to answer, so explaining the techniques, and we can chat and discuss later. Thank you.
Okay. Yes, thank you, Samuel, for the presentation. You can now join your seat as we welcome our last presenter. And our last presenter will be Sion Prasad. And Sion is a student at Harvard University studying engineering, data science, and global health. And she's also part of Dr. Bethany Health Gethbach, if I pronounce it well, I don't know, lab at the program in global surgery and social change at Harvard Medical School. Sion will take us through her research about development of a robust surgical site infection diagnostic algorithm for women post-C-section. You are most welcome, Sion.
Thank you. Can I have my slides, please? Hi, everyone, and thank you so much for this opportunity. My name is Siona, and my work is on developing an algorithm to diagnose surgical site infections. Next slide, please. Next again. So surgical site infections are one of the leading causes of maternal mortality, and we find that they're very prevalent, especially for women after C-sections. Early diagnosis and treatment of these infections is key, but we find that there are very high barriers to receiving care. So many of these women have to travel long distances to hospitals, and that can be financially difficult and is linked to poor outcomes. So the goal of this overarching work is to bring that care to the women's home, and we hope to do that using mobile health tools and also by leveraging a system of community health workers. Next slide, please. So what does this look like? Essentially, a community health worker would take an image of the wound, as shown on the left, And then a smartphone algorithm would take that captured image and use it to predict an infection. Next slide, please. So in order to train that algorithm, we needed training data. And so we collected wound images from 570 women at Crehe District Hospital. And then we also collected the general practitioner's diagnosis of infection. Next. The goal of the algorithm was to take that wound image and see if we can actually predict the GP's diagnosis. We used a machine learning algorithm that's based on a transfer learning framework, which is a very powerful and new deep learning method. And this plot on the right shows is a visualization of the model's performance, and we're trying to maximize the area under that curve. And we find that our model performs very well with an accuracy of 94%, and this shows the promise of this technique in diagnosing infection. Next. However, what we find is that a problem is that a lot of these images are not standardized. For example, if we take an image in this lighting, it looks one way. But suppose the lighting is really low, the image will look another way. How do we know that our algorithm works no matter what? So to test that, what we did was we introduced some changes in our images. We reduced the brightness, the blur, the contrast. Next slide, please. And what we see is that our algorithm still performs well even when the image quality changes. So on this first plot, we see that as brightness reduces, the model accuracy still remains high for a while, and then at very low brightness, it falters. And so in conclusion, we see that there are minimum thresholds for image quality that we need, and that's very important to know. So these results demonstrate the potential for this algorithm, and it's an important step to sustainable home-based care. Thank you.
Excellent. Thank you so much, Sion. Also, you kept time, 2 minutes, 42 seconds. So do we have questions, comments for Siona?
Magnifique. The question is, Siona, thank you so much. Do you have images of a wound, of an infected wound that you compared with a wound that is not infected? For your computer to actually, for the image to qualify to be an infected wound, are you comparing it with an image or are you comparing it with a doctor, with a doctor's knowledge? Because that, I think, would be a little bit different. Thank you.
So this is one question. One more, please. Yes, do we have a question that side?
Thank you so much. It's Victor. My question goes about what are your hypotheses about the difference in sensitivity and specificity? Like.
Okay, yes. So for the first question, we used the normal way a general practitioner would diagnose a surgical site infection as the label on the image. So it wasn't based on a visible look at the image. And the reason for that is that would be the standard of care that the woman would receive if they were to travel to the hospital. So our goal was to see if that we could predict that same standard for the women using our technology. And then the difference between sensitivity and specificity. So sensitivity is how well we're able to classify positive images, so the ones that are infected. And then our specificity is a measure of how well we are able to diagnose the non-infected images.
Thank you. We have 1 more minute for Siona. Yes.
Thank you very much. I would like to know when the picture is taken after surgery.
Yeah, so this was important. I should have mentioned this, but the woman returned to the hospital on postoperative day 10 or 11, plus or minus 3 days, and that was when the image of the surgical site was taken.
Thank you for the great presentation. I have one simple question. Have you considered the topology of the wounds or the site that was infected, so that if you are optimizing the deep learning technique, you can tell us that at any given, for any given topology or stage, the technique was effective and optimally learning? Thank you.
30 seconds here.
Right, so we have, our current work only looks at the images on postoperative day 10, and it is just a visible image of the surgical site. But my partner's Monique, she's working on taking a thermal image of the wound, which hopefully is more generalizable. And then we're also working on work that takes postoperative day 3, so a much earlier stage, and seeing if the algorithm stays robust to those images as well. And so that's a great recommendation. We hope to explore all of that more as well.
Thank you. Thank you so much, Sion. And concluding, I would like to express much appreciation to all our presenters, to Eli, Chrislene, Varen, Samuel, Prasad, for taking part of this competition. If we would appreciate them, please. And then this was a kind of competition, and as we are making our students exposed into how they can pitch, discuss, or showcase their research results, but we are also looking more forward into more networks and collaboration. So please interact with them if you have similar field of interest or some more recommendation for their work as they grow in research. And I will turn on over to MC. Thank you very much for your participation.
That was great. Thank you so much. We're almost coming to an end of the morning session, and this was a great session, at least in my perspective. I would like to make a few remarks as we're heading to lunch. Lunch is the same venue like yesterday, Rwanda restaurant, which is by the sides of the hotel. Secondly, we need to be very, very, very time sensitive this time because the sessions in the afternoon starts immediately at 2, and then we have a session here and another session is in the mezzanine upstairs like yesterday, and they are all going to have different speakers and presenters on their research. Please turn up for the afternoon session. So in the afternoon session, again, we'll have a time to award the best pitch, research pitch from the presentation. And we also have time to get an idea of what we actually have been able to achieve during this 3 days conference. And of course, we have the closing ceremony. And after that, we'll have a networking cocktail. Some people are so much interested in the networking cocktail more than the afternoon sessions, but it's okay. So now we're going to have a 2-minute video of what actually happened on day 1 at the University of Rwanda for the United Health video. Let's have the tech team get us that 2-minute video, then we need to... Yes, thank you. Just one more clarification. Lunch is at Filini restaurant, so you don't need to go all the way to the hotel, but it's right at the entrance of the Kigali Convention Center, this building we are in. Then that's where the lunch is. Thank you. Enjoy your lunch.
Moving up front. Thank you very much for again coming to this afternoon session. whereby we shall be having a round of abstract presentations. So we want to connect the first day, the second day, and this last day. So we want to discuss more about the innovative practice for better health. And to this, specifically for this room, we are having 5 presenters. And I just wanted to change a bit on the agenda communicated before. We shall be having all presentations at once. And then after, I will request the presenters to stay at the stage. As they are presenting, if you have a comment, a question to ask, or more clarification from what they have been presented, we shall get it at once. So it's for interest of giving time, and later joining with our fellows in the other room to have a one closing session at once in this room. So without taking more and further ado, let me welcome the first presenter, Ms. Clarisse Musana-Baganwa. She will be talking more about assessment of knowledge and perception of precision medicine in our settings. So Clarisse, she's working with RBC, and she's a doctor to be a student. She's pursuing her PhD candidate, and most of their talk there within her thesis. So welcome, Clarisse.
Thank you very much, Dr. Gaika. It's a pleasure to be with you again. Good afternoon. Can you please put the slides? This one is not. Yeah, so I just want to thank you for the opportunity to share with you some of the findings and current progress for Rwanda to promote precision medicine in Rwandan healthcare settings. You will excuse us a little bit. They put some slide there. Great. Next slide, please. Yeah, precision medicine, as you may know, it's an approach for treating patients by considering individual differences in terms of lifestyle, genetic diversity, environment, and family history to improve the prevention and treatment of patients. Precision medicine is specific to an individual compared to what we are used to, what we call a one-size-fits-all approach, which usually focus on average patients. So precision medicine comes in to really improve healthcare by focusing on individual differences. Next slide. Precision medicine again aims to, as I mentioned, to help clinicians and healthcare providers to really provide tailored therapies by focusing on individual differences, as I said, again, by aiming to target the right patient in the right time with the right treatment. Next, please. So just quick background, Africa is one of the continents with high genetic diversity, which is normally like influenced by admixture and other ancient divergence, which really changes our genome and hence influence the genetic diversity for African population. So there are so many initiatives going on at African level, and H3 Africa is leading or is driving those initiatives. There are many enablers that have been put in place to influence or to promote precision medicine on the continent of Africa and even across the globe. Like there's, of course, political will, good governance, data sampling, sharing, promotion of legal frameworks, and other different steps like promoting digital technology for precision medicine. Of course, we expect many benefits from precision medicine at global level and also at in the African community. So at global level, we think it is going to add value for different genomic databases that are going to be used while producing or discovering new therapeutics for patients. And of course, it is going to help us to really bring that to improve healthcare outcome for African population by considering African diversity while shaping or providing treatment to our population. Next. So these are key strategies which were put in place to implement precision medicine. As I mentioned, there are many. Among them, of course, we need to do basic research to make sure that we produce those data which are needed from genetic level so that we have the content or the information related to our population. We need to put in place social and cultural knowledge, health infrastructure, feasibility assessment, population health impact studies should be implemented, and individual health impact. So all these should be accompanied by making sure that we have human resource capabilities able to implement precision medicine in the health setting. Next. So when we talk about translation medicine in Africa, there are many technologies which were established, like genome-wide association studies and other different platforms which were able to identify genetic variants which are linked with different health conditions. Among them, you can see that these are genes which were detected in our African ancestries, which are linked with different diseases like malaria, like cardiovascular diseases and others. But of course, there are still challenges. Most of these high-quality precision medicine products are benefited by developed countries. And most of the reasons which are linked are that the genetic diversity for African population is not recognized when we are producing therapeutics in general. Next, please. So as Rwanda, in the past 4 years now, Rwanda decided to consider precision medicine as one of priority on the agenda. And they, in a collaboration with the World Economic Forum, they have been able to establish capacity building to start really promoting this precision medicine in the country. And different efforts are going on. As I mentioned, capacity building, establishing legal frameworks, making sure that we are producing those genomic data, which informs about characteristics of our population at biological level. So there are many flagship projects which are going on in the country, but all of them are categorized in three. We have human resource capabilities, genomic data production, and biobank creation. In terms of human resource capabilities, we've been started to really establish or train young researchers who are coming in that field, genetics, genomics, and others, to make sure that we have skills which are necessary to drive the efforts. Of course, for genomic data production, we have other projects where we are producing those genomic data, like those on stress. We have already identified genetic variants which are linked with PTSD and depression in human population. And all those genomic data have been uploaded in different international databases, and we hope they are going to help in this decision, in future decision of discoveries and improving healthcare. Other important flagship project is on molecular characterization and genetic mutation-driven breast cancer in Rwanda. This is an ongoing study, and this one, we are building a big biobank where we are extracting DNA and other different biological biobanks that we are going to use to really understand the genetic diversity and mutations that are driving breast cancer in Rwandan patients. These are quick flagship projects that we are using to really promote precision medicine in Rwanda quickly. So as I mentioned, within this ongoing project, one of the specific objectives was to assess knowledge and perception of healthcare providers on the implementation of precision medicine in Rwandan setting. Why we thought to really combine this component with those high-level scientific research objectives. We wanted to not only produce those research output or bringing out those new variants or new genes without knowing how these health settings are going to use those information to improve the healthcare. So we added that component to understand our the knowledge of our healthcare providers. How do they understand precision medicine, and what are the perceptions? Is it possible, is it feasible to implement this kind of technology or advances in the healthcare? So this was a descriptive qualitative study which was conducted in 7 healthcare facilities which provide diagnostic and treatment of breast cancers, including Sehashika, Sehashibe, King Faisal Hospital, Rwanda Military Hospital, and Butaro. It was a key informant interviews which involved a purposive sample of 30 participants, including decision makers at national level and 25 healthcare providers in the selected health facilities. Of course, we did 5 additional direct observations where we used a 7 items direct observation checklist to check the available infrastructure in the health facilities, and we wanted to see if the existing technology that we have can be a starting point to say that Rwanda is ready to leapfrog in that practices. Of course, all interviews were recorded, transcribed, and were analyzed by you in 5 sub-teams with different codes. Next. As a result, in terms of general perception about concept of precision medicine, we asked them about how do they know about precision medicine. And interestingly, 63 to 100% of respondents, they mentioned that they had adequate knowledge. They scored around 4 to 5, which was the highest score. And others mentioned that it is their first time to hear about the precision medicine. And some others also say that they heard about it, but they don't have an idea of how to use it in their practices. So these are quick highlights on how they defined precision medicine, and it is very interesting because like you can see that they say that it's an approach which is providing targeted cancer management and treatment, but even some prevention intervention. This is how they went in defining, but you can see like the green one, they have been able to really mention, to say something about customization of treatment based on lifestyle, based on genetic diversity. So this is a good news for Rwanda, for policymakers to see that at least they know what it is. Next. The willingness, we also checked on the willingness of institutions to invest in precision medicine program, and we've seen that 48% of respondents confirmed that the institutions are willing to invest in precision medicine. Next. And of course, we went in and we asked if there are some individuals interested to implement precision medicine at their own, and we found that 19 out of 30 respondents responded that they are willing to really do such kind of practices. Next. So these are barriers which were highlighted to implement precision medicine in Rwanda. The most cited is lack of supporting infrastructures and technology, and the other is on lack of financial resources, and culture and behavior and religious beliefs are considered as barriers to hinder precision medicine practices in the country. Others that were mentioned include like the practice is not cost effective, it's very expensive, low priority of precision medicine in those institutions, lack of information on determinants of diseases, like burden of diseases, lack of clear education of that concept, and concerns of ethics and legal frameworks. Next. So these are again quick highlights from the respondents. Some are saying that traditional healers and culture and beliefs are also impacting or hindering the progress of implementing precision medicine in the country. And of course, they say that limited finance for our community for co-paying health insurance is also one of the barriers to really implement precision medicine, as most of the treatment linked to precision medicine would be very expensive and will not be covered by health insurance at 100%. So in terms of capacity building, as I mentioned, this is also the main target, to improve skills of healthcare providers in the domains which are driving precision medicine. 74% of respondents mentioned that training genetic counselors is very key, and also training scientists like molecular biologists, biotechnologists, bioinformaticians, it's very important. Of course, they also mentioned that there should be a program for precision medicine at undergraduate and master's level, and that will help to leverage the efforts of promoting precision medicine. Next. Of course, some of the respondents highlighted that strong human resource capacity building in precision medicine should be key in progressing with precision medicine. Next. So in terms of data privacy and data and privacy for patients, as you may know, you cannot talk about precision medicine without data. You cannot talk about precision medicine without privacy and assurance that those information, especially genetics data or those data which are touching on genome, there are risks that if the privacy is broken, those information can be bring consequences to the community. So we found that most of the data collected, it's on clinical and demographic information are well collected, but health facilities do not collect genomic data. Only one health facility is able to do the genotyping. In terms of data privacy and confidentiality, 92% of those participated study sites mentioned that researchers they share information, and it is a good practice for implementing precision medicine. And they say that they share the information to stakeholders, but with respect to ethical standards and national research regulation. And 80% of those study sites also mentioned that they are having their own review boards, which are able to ensure that ethical aspects are taken into consideration for this. Next. So for leadership and governance, next please. We also wanted to see what are the perceived changes that we may really advocate for so that we can progress quickly for this implementation. We've seen that some of the respondents mentioned that integration of precision medicine in the existing health system would require to update the policies, the current health sector policies, and also would require to establish some guidelines to guide researchers how they're going to use the biological samples to ensure that they are being useful in informing the current practices in the health setting. These are also quick highlights of some of the respondents saying that increasing awareness about precision medicine would be a way to go to really leapfrog on the initiative. And also some mentioned that we may update those health sector policies, but there is no need to have a separate health sector policy, precision medicine policy as a site. We should update the existing documents and make sure that they are highlighted, the needs and priorities are highlighted in the current policies that we have. Next. Of course, they mentioned that we should advocate for promoting precision medicine, and also they suggest that introducing specialized training for precision medicine, as I mentioned, is very key, because without human resources, which are capable to do those specialized testing and research activities, it will be hard for them to really provide to improve patient outcome. These are also quick highlights, like revising curriculum for universities, undergraduate and master's program, by including precision medicine courses. And also they mentioned that engaging partners is very key to make sure that we are closing the loop for related to gaps that we have in terms of infrastructure and technology. And also they mentioned that it's better it is better precision medicine being part of health sector strategic plan to make sure that the next planning should be, there's a budget allocated for those activities. Next. So all participants also had a positive perception about fitness of precision medicine in the existing technology. Some mentioned that the current infrastructure in terms of lab, like National Reference Laboratory, they have good technologies, they have good machines, but what they are missing is that continuity of having reagents in place, having those human resources who are able to do that. So at least we have a starting point. And others also mentioned that the minimum to implement research activities, at least now in our health setting, we are able to do the DNA extractions. We are able to do, we have those biobank on some of the projects that we have already implemented. So it's a good start to really leapfrog on the initiatives. What is also needed is just coordination and collaboration. Next. So as a conclusion, precision medicine is perceived as a complex approach, which won't be easier because it requires human resource, finance, and other things. But of course, with the kind of collaboration, we believe that it might be possible. But with the response from the respondents, some of them are saying that it will not be possible to implement it without allocated funding for upgrading infrastructure, equipment, and reagents. Of course, also we need to use the genomic data, build human resource capabilities, generating genomic data, as I mentioned, and also making sure that we engage our partners to make sure that the gaps which are there can be really removed with collaboration and engagement of partners. So with that, I would like to acknowledge the research team, which is part of this flagship project, and institutions which are involved. University of Rwanda, of course, National Commission of Science and Technology, the funder, and those health facilities involved in the implementation of the project. I thank you very much. I will welcome your comments and input.
Thank you very much, Clarice. As I said, we shall have at once all presentations, and after the last presenter, I will request all presenters to come on stage, and we shall have one round of questions and answers. So to this note, I request everyone who has a question or some clarification to note it down on your notebook so that we can have asking it at once. So let me again welcome the next presenter. He will be talking about shifting from 3 multi-month prescribing of ART to 6 months prescription, and this was associated with non-inferior outcome for adult on ARVs in Rwanda. So Dr. Brian Kwizera, he will be talking about this. Thank you very much.
Thank you, Dr. Gallican. I want to thank you all for coming for the presentation and for the organizing team to have selected my abstract to be presented to you. So as an introduction, thank you. So as you've heard, the title of this abstract is Shifting 3 multi-month prescription to 6 multi-month prescription was associated with non-inferior outcomes for adults on ARV in Rwanda. So this was a study done with contribution of RBC HIV division and ICAP in Rwanda. So I also caught the contributions of the co-authors of this. Next presentation, next slide, sorry. So as a background, we know in Rwanda there's been an increase of clients that are eligible for ART, given that with the introduction of Treat All in 2016, we've seen many clients being eligible to go on ART. So this questions the quality of services they are receiving, because we know that facilities are overwhelmed with receiving a number of patients that are many, And so we adopted the WHO guideline recommendation in 2017, which was multi-month prescription, which means it determines when a patient will come for their ART pickup. So we have patients before that were on 3 months of prescription that we are shifted to 6 months of prescription of ART. So our rationale behind this was we don't have any study to talk about whether these patients are being retained in care or whether they are viral load suppression, since it's the gold standard to know that patients on ART are really actually adhering on ART and doing well on ART. Next slide, please. So as you see, this shows the trend in the shift in a very short time during the COVID period. We saw that actually differentiated service delivery, which includes 6-MMD as an enabler for patients on ART, was really a good start of, came in the right time. So we saw that many patients were shifting to 6-MMP, and the eligibility criteria was that a patient had to be on ART for over a year, having a viral load suppression, 2 consecutive viral load suppression, and being an adult. So this informed us on which patient that should go on 6-MMD. But the question remained, are they really coming back to care? Are they viral load suppressing, given that they are taking long to come for their clinical checkup? Next slide, please. So we reviewed charts. We reviewed charts of clients on 3-MMP for the whole year, and we compared them to those that were on 6 months for the next year, the same patient population. So it was one cohort. So we abstracted data looking at viral load tests, and this consideration was a viral load test that is not detected, which is we define as viral load equals 0, and undetectable viral load, which is less than 20, and viral load suppression, which is less than 200 copies, according to Rwandan national guidelines. The iteration rate was defined as reporting in time, 1 week in time, for ART pickup and viral load test. So we used the paired t-test to compare the viral load test and retention rates of clients in both models, and the viral load absolute values were log transformed, since there were some skew values, and analyzed for either their mean and their median log values. Next slide, please. So out of those, out of more than 10,000 people living on having HIV that were enrolled in the study, there was no significant difference in the mean log values of the viral loads. So as you can see, one was 1.32 and one was 1.33 in both periods. And then we had 28.7% of people living HIV had the viral load not detected in 6-MMP, compared to that 22.7 during 3-MMP. So this shows actually that 6-MMP was more beneficial than 3-MMP. But on the other hand, go back to the same slide, the proportion of people living with HIV with the viral load suppression during 6-MMP was very high, being 99.4, but slightly lower in those on 3-MMP, which was 99.8. The confidence intervals here were strong enough to come up with this conclusion, and the p-values were also significant. So retention improved with exposure time from 67% to 74% over the 6-month period of ART exposure. So the stratification showed no significant difference for both sex and age. Next slide, please. So what we can make of this is that the transitioning of people established on ART from 3-MMP to 6-MMP had no major effect on viral load outcomes, which is our gold standard to know whether patients are doing well on ART, and retention improved with establishment on ART. So what we call establishment on ART, according to WHO guideline, is a stable client that has been on ART for over a year and has a viral load suppression. Next slide, please. So as a conclusion, we recommend that HIV programs, be in country or outside of the country, should consider offering patients the multi-month model, which is 6MMP, and we've seen a raise in our clients going more on 6MMP and doing well on 6MMP. All it needs is to follow them up in their communities and ensure that they are actually following their prescriptions. So multi-month prescription tailors HIV treatment and care services to meet the needs of people living with HIV. And as a result, this decreases the cost on which they have to travel every time they have to come for their ad pickups. And it also reduces pressure for our providers in the health facilities. And also, it enables the patient to take their health in their own hands. Thank you so much for listening in.
Thank you so much, Dr. Brian, for keeping it more brief than was expected. So allow me to welcome the next presenter. He'll be talking about the prevalence and risk factors associated with hepatitis B and C infection among NCD patients in 3 rural Rwandan districts. And this is a retrospective cross-sectional study. So, Mr. Msafiri Tumusime, please welcome.
Thank you very much. I'm glad I'm following Brian because from yesterday we were having like every presentation we were rating digital solutions presentations, and mine there is no digital solutions. So I was scared, do I have to present my slide without digital digital solutions? And he's encouraging me by now. So my presentation is about hepatitis. Viral hepatitis it's an international public health global threat. So we partnered in health, conducted a mass screening. Next slide, please. Thank you. So partnered in health through infectious disease program, they have conducted mass screening, which is at least a micro-immunization. We are targeting, normally in Rwanda, we are using mass screening, and from PIH, we have formed another strategic plan, which is using micro-immunization mass screening. Instead of having mass screening, at least we would go for subgroups. So here, that's why we went for NCD patient, and we wanted to see the prevalence and risk factors related to them while acquiring hepatitis B and C. Next slide. So during the screening, we had to do different activities, preparatory meetings, like having meetings with local leaders, director generals, health center facilities, and also so that we can make our mass screening, our screening more smoothly comparing to other activities. So we had also to do community awareness so that our activity could be known by community and even the local leaders so that they can be supportive to make it productive so that our patient got treated and as it was planned. Then, how do we go to the patient? This is where our technology comes in. The patient, we had to generate list of the patient from clinical health facilities, different health centers. You had to generate the list of patients so that we can gather the list of patients so that we can reach them, even if we wouldn't able to get them all, but we had to use the community health workers, or some of them we could call them for those who had phone, though it is still the problem. Many of the patients, they don't have the phone, which I think at least we could think about it when we are here as when we get lucky to be in front of the policymakers, at least we do have that problem where you can't find the patient in time where they are needed. Next slide. Methodology, we reported the prevalence and 95 confidence interval of hepatitis B surface antigen and the hepatitis C antibodies. We assessed for association between hepatitis B surface antigen and hepatitis C, and sex and age, NCD diagnosis, prior history of hepatitis, screening using Fisher exact test. We also compared our findings because we wanted to see how is the magnitude of our findings to compare to the national prevalence that has been reported from RFA. Next slide. Then from our screening coverage, we wouldn't get it all, like, we didn't get 100%. We are 70, we got 76%. And NCD patient were older than the general population, that's known. Most were receiving treatment for hypertension, almost more than 79%. They were hypertension patient. Next slide. HCV prevalence was higher with 5.9%. And as seen in previous research, older age was a risk factor for HCV. After accounting for differences, age and NCD patient were not at high risk of HCV prevalence than general population. Here we are talking about after, if you can see from the second column, where there is 5.9%. At the beginning, you would think that when you compare to the country, to the national prevalence, which is 1.2, you would say that NCD patients, they are very, very much higher comparing to the national prevalence. But we had to do standardization, which at least make a sense by bringing in the common sense of understanding that after doing the standardization, we came to find that it was 0.98%, the prevalence, which is at least a little much less than the national prevalence, which is 1.2. Next slide. And then repeat screening was common with 46.6% self-reported prior hepatitis screening. And 2.6% of Kirehe and Kayonza residents already documented as HBV, HCV positive. Here it's where the problem is. We do have a lot of patients who have been screened in different mass screening, but they haven't got any opportunity to get the treatment due to the different issues. Some of their blood were taken for confirmation, and they didn't get the results. So they have been waiting the results, and when any mass screening happening, they have to attend without any further consideration of their issues. They are being complaining, they do have that issue so that they can be solved. So if we are here as at least the decision makers, at least as the policy makers, we should look around to this issue. It's a big problem there on the ground. Repeat screening significantly was associated with hepatitis B, and we know hepatitis B, it's a disease that you have to live longer with us. It is not treated. So if it is not treated and the patient is there, down there, he's waiting the treatment, and he is not being offered the treatment. So what's wrong? And we are supporting the depression for her or him there in the community. Next slide. The targeted screening among NCD patients was accepted and feasible. From there, we are considering our microimmunization method that we are using. So we started with NCD patient. And from our point of view, at least we have seen that it is possible to use microimmunization starting from sub-operations so that they can be supportive and even easy to reach, easy to manage, so that they can achieve their treatment. And HCV prevalence among Rwandan patients was high likely due to their older age. So we know normally that HCV is related to elder age. When you are getting old, it is high likely to develop the HCV due to the previous factors, all different factors that are affecting. Repeated screening and elevated hepatitis risk among repeated screeners suggest suboptimal linkage to hepatitis screening. This is an issue, like I said, they keep coming, complaining their needs for treatment. So every month screening they have to attend. Next slide. As a recommendation, NCD patients are a good candidate for HCV microimmunization campaign in Rwanda. That's why we are trying to say that at least this method can be used in another district rather than the PIH supported district, because we have tried to manage that. But other districts, they can be even supported through microimmunization so that they can see. By the way, though we haven't talked about the linkage to care and the impact of outcome treatment, which I think it will be our next paper. I'm sorry, Dale, I did mention that. It's our next paper. We have seen that the NCD patients who have been confirmed for HCV, they have high viral load. They are more than 2 million, very high. When you know viral loads, they are more than 2 million, which means that these people, they might be treated by hypertension or diabetes treatment, but they have something else that is making them suffer than those treatments that are being given. And then you see your patient is not improving because of he's got or she's got another strange disease that she's endangering her or his life. Following NCD patient up through the NCD clinic may help improve linkage to care. Next slide. Okay, lesson learned from the implementer, reagent stockout, lab capabilities. We all know this. We have been meeting this issue during our screening, where we had a problem of reagents in different labs that we are working on, Kilehe, Winkwavu, Burera. So those areas, we had a problem of reagents. Reagents, I'm talking of reagents, PCR for confirmation, and even some of the other commodities that we have to use while conducting screening. So electronic data, this is where, again, my digital solution comes in. So it is not easy to conduct a screening when you are using only paper-based. We know all mass screenings. Peter is here. He's not here. Peter from Chai. So we have seen that a lot of those screening they were using a register box, and some of them they were lost. So because of what they were not technology that they were supposed to be. We are lucky in Partner Health because we are using Redicap as software, at least to be conducting our screenings. But on the other hand, on the district level, they were not having any software. So at least by now, we are lucky we do have DHIS. DHIS too, they do have a lot of work to do. Because we do have a lot of patients who are there without treatment, and even they can't be found anywhere. So at least if you increase the effort of using DHIS to any other health centers, so it will be helpful through supporting linkage to care, support implementation, opportunity to standardize, using DHS, everything else will be done, at least with the help of DHS too. Next slide. We would like to express our deepest gratitude to the NCD patient, of course, because if they were able to comply, we wouldn't have these findings. Community health workers, health centers, PIH, team of Uzima, mu Kinyarwanda cyacu, and by the way, within my department, infectious disease program. Also, Rwanda Ministry of Health, through Rwanda Biomedical Center for their continuity support to our community, to improve our community. Also, I can't leave behind my co-authors for whatever we are doing to make this manuscript going well. Thank you for the organizers of this conference. Thank you very much.
Thank you so much, Musafir, for this good output, and to say that it's one of the most needed to close our gap and a good contribution to our national hepatitis program. So we, as I said, we are again swinging in between the NCDs and infectious disease, mainly HIV. So our next presenter will talk about early virological outcome and of DTG-based regimen in adult naive patients living with HIV. So Dr. Simeo will take us through this presentation, and to highlight, Dr. Simeo is Director for Care and Treatment at RBC. Thank you very much. Welcome, Doctor.
Thank you very much. Good afternoon to everyone. Yes, the early virological outcome of the DTG, or the dotography-based regimen, in the adult people living with HIV in Rwanda is, next slide please, is a study or study aiming to understand at least what are the very first outcome of the DTG as integrase inhibitors in the treatment responding to the HIV prevention, HIV response. As there has been a new drug being represented elsewhere, it has been evidenced that in different randomized controlled trials that it has like superiority against non-nucleoside reverse transcriptase inhibitors and protease inhibitors. But also we could understand it in Rwanda that we are having the same trend. The aim of this study then was to understand after the initiation of the treatment for those who are not having, for those patients who have been on treatment at least for 6 months, which is the very short period that the HIV program used to test for the treatment outcome, to compare the DTG virological outcome with other based regimens in HIV treatment. We were comparing this considering the viral suppression for after this time of the 6 months on antiretroviral treatment for the patient who has not been previously on treatment. The methodology of this study was to use, next slide, we used the cross-sectional study, and we reviewed different results for the clients routinely collected from the viral sample management system. This is a routine program monitoring the outcome of the clients who are on antiretroviral treatment. So we pulled out more than 16,000 clients living with HIV. We put their results and tried to understand for those who have been enrolled in treatment for initiation on DTG between 2018 to 2020, trying to understand what is how their outcome are different in regard to the treatment they are taking. This was a cross-sectional study, I said, and it was mainly basing on the data collected from the viral sample management system, and was considering a viral suppression cutoff at WHO recommended measure, which is 1,000 copies. Next slide. On the time of on the results, you could see that initiation of the DTG, as we all know, it has been swinging between acceptance and also some other recommendation, making it in lagging a little bit behind. But from there, it has been shifting from 29%, yes, 29.8% to 54% in 2018 to 2019 to 2020, respectively. And with this, it has been showing a little bit of superiority, or comparing, also responding to the same studies across the borders, which has been giving out the different biological outcome improved on the DTG-based regimen compared to other regimen people were taking. This has been conducted in the whole provinces of the country, and the most represented province of the country was Kigali City, actually. But also the whole provinces were closely similarly represented. As I said, we could see that unsuppression during for those clients taking non-DTG regimen was a little bit seeming to be higher, as you can see. Unsuppression for those on DTG were compared or having a little bit 2.6% versus 4.7% in the DTG regimen versus non-DTG based regimen. Yes, of course, we've trying to adjust all other different factors, but you can understand that there are some other factors which need to be clearly well structured to be adjusted, like adherence on treatment for those who are taking, for those clients as they are being recently initiated. If we go next, which I think is next slide, is a representation of those information I was saying, and you can see clearly that there are different proportions of the DTG-based regimen versus those non-DTG-based regimen, but also the representation on the other side showing a little bit provinces closer and slightly higher in Kigali City. The next slide is about our recommendations. We took that DTG being a new drug, a new molecule introduced in Rwanda recently in the past few years. Some of the patients were even scared to take this and associating it with some other effects. But also, we embrace that its effectiveness having being represented from different other cities across the borders is also being the same case in Rwanda. And we even joined the WHO recommendation trying to put it in, to introduce it even in children, for those who are even less than, for those who have like 1 month of age, without having any other complaint from them. I think we still have a journey to understand and to make the clients understanding that this regimen is making them working. It's also working better, despite that there are also some alternatives working around. But also we encourage to have this optimizing outcome of the new treatment working with them, and also understand that with the new drug, this review was not considering clients who aged less than 15 years. Therefore, we need to understand their group too in our settings, and also consider how they may be responding to the treatment in different ways while being treated. We also recommend that maybe further studies and even further understanding of this molecule will protect it against different treatment resistance and provide the better outcome to even prospectively going to, as we are responding to the HIV epidemic. We think the representation of this to present this, we'll also be calling upon further researches to deeply understand what we can do and what also this DTG, the characteristics on how responses are being from different clients, from different patients receiving this the same drug, and also to protect it from the early resistance and the mutations. And the next slide, I think, is to thank you very much for your kind attention, and also acknowledging the support and also the response, the HIV response from the Ministry of Health, Rwanda Biomedical Center, understandably, but also different partners, the government partners in HIV responses. Also, thank my team who co-authored this work, and thanking you very much for your kind attention. Well.
Thank you so much, Doctor. So, as we are making the last presentation, I would like to remind you that kindly note down your question. After this presentation, we shall be having a round of questions and answers and clarification. And as we have many people in this room, the providers, the researchers, and other people contributing to various research and national response. So we are looking forward to have a more interactive session ahead. So we are going to receive a last presenter to this session. Heltien Fura will talk about innovation to facilitate communication in health service delivery for mostly deaf patients. So welcome, Heltien.
Good afternoon, everyone. It is also our privilege to take part in this year's Health Research and Policy Symposium with this year's theme, Digital Solutions and Innovative Practices for Better Health, which really fits with our project. So it is titled Innovation in Health Services Delivery for Deaf Patients, and I'm Heltien Fura with my colleague Clemence Ishimwe. We are MBA's 2025 student, third year medical student from UGH. Thank you. So, hearing disability according to WHO is defined or was postulated to be the fourth leading cause of disability, and in 2020, 466 million people were deaf, and it was estimated to double or reach greater than 900 million in 2050. This is mainly due to different chronic conditions affecting the ear, maybe meningitis, chronic otitis media. Some are congenitally acquired, and a lot of other causes or factors. And in Rwanda, according to Ministry of Health in 2018, 0.4% of the population were deaf. And this constituted like 15% of all disability taken together. So health disability is a challenge in healthcare. So both healthcare providers and deaf people really face challenges while receiving and others delivering health services. And these lead to poor health outcomes, low health knowledge, mistrust in health providers, and delays in seeking health services. So currently different existing interventions do exist, including interpretation services, sign language training, and communication technology. All these are used to really facilitate such kind of population. But as we'll see the pitfalls or downfalls of these and what our project aimed to improve. So our problem was challenges in communication between healthcare providers and deaf patients cause really are there, and they cause poor health access and outcome. And our solution was to develop an app that can be used by deaf patients and health providers to communicate and solve that problem. So we went through the designing, or this renowned process of design thinking process, where we go from empathizing with the users, defining the problem, ideating ideating what innovation you want to put out, prototyping it and testing it, and then coming back to get feedback as you innovate your prototype and finally put it out to the market. So my colleague is going to take you through how we really follow this algorithm with our project.
So my name is Clémence, Ishimé Clémence. I'm also a medical student in the 3rd year. So for our project, this is how our designing thinking process became. So first we had to identify and contact our users. So those were going to be the deaf patients and the healthcare providers. Then gather information from them to understand how the kind of challenges they face and how they wish to kind of resolve them. Then create our tool, which was going to be an app, test our tool, our prototype, then go back to our users to get feedback and modify it to be more appropriate. After identifying the process, we took action. First, we had to find some partners. We were able to partner with the University of Global Health Equity. We got support from the Rwandan National Union of the Deaf, Babson College, who provided 3 students who are working with us, and they've all supported our idea and have been working with us for about 2 years. So we went on to understand our users. We conducted several interviews with a few members of the deaf community, and went to different health centers to talk to different healthcare providers, mainly in Burera district, and they shared with us some of their concerns, challenges, and how we can help them to find solutions. Through those interviews, we found a few things. So indeed, communication was the main challenge that was faced by health care providers while treating deaf patients. And deaf patients reported that their challenges were from the reception. So by arrival at the hospitals or health centers, communication barriers were the problem, and they faced them up until to the pharmacy. So the whole process of seeking healthcare services was challenging. We also found that some solutions have been working for them, even though they're not the best. So they've been trying to write using pen and paper. But then most of the deaf community is illiterate, so they can't write or read. And some of them use interpreters, but they rarely use them because very few of deaf patients know how to sign, how to use sign language. And of course, using interpreters didn't really respect the patient's privacy. And what we found is that most of them use family members. They go to the hospitals with family members. But that was a challenge too, because the family members also don't have an accurate way to communicate with them. So when displaying that information to the doctors, it was incomplete and didn't really work for them. So in the end, our solution was to create an app that used pictures, photos, that displayed different signs and symptoms, and then could also show different clinical instructions, and that could work for both the patients and the doctors. This app would not require to be literate, so you wouldn't need to write or read, which helps because this is most of the population we want to reach, and it wouldn't need internet, to mean that both urban and rural hospitals and health centers could use it without difficulties. So now we have a prototype, and it involves first pictures that the patient can choose from. Pictures are clear and they clearly display symptoms. The patient can choose from them and then submit. The doctor would then see a list of the selected symptoms. Then the doctor would also select different instructions or interventions that the patient is supposed to receive. As you can see, if a patient is going to be hospitalized, if the patient is going to give a urine test or a blood test, the pictures clearly show it and the information is clearly displayed to the patient. So to continue, after having a prototype and we also received positive feedback from our users, we've decided to focus on one service as a start. So we're going to first focus on the antenatal care services. These are very important. The country is also trying to kind of support this kind of services. So we decided to do that first. And if our start with this service goes well, we will then improve the product and use it for other different health services. Later, we are planning to do a research as a way to measure the results. So research that would try to see the impact that this product will have had on the deaf community. Thank you.
Thank you very much, Alicia and Clemence. So, as I was informing earlier, so we are going to have a session of questions and answers, and I would like to request our presenters to come here on stage. Of course, you have been keep noticing that our attendants and participants may have questions that they noted down. So may I ask Clarice, Dr. Simeo, Dr. Brian, Tumsime, and Clem Eritier to please come step forward. And we have a microphone here. If you have a question, please address to one of our presenters. And we still have 20 to 30 minutes for this session. So you're having a microphone. There's a question to this. We may even use this.
Thank you very much. I'm Vivian Muhire. My question goes to the person from PIH who presented about hepatitis C virus screening in people living with NCDs. He mentioned that there is no risk found for, there is no difference to the prevalence of the country or on the hepatitis C virus among people living with NCDs. And my question is, the research is good, first of all, let me appreciate. And again, what is the sustainable solution they are planning for even those few cases they found among people living with NCDs. What are they planning to do for them as long as they screened for hepatitis C virus? And again, the second question branched to that. What is the sustainable solution for all NCD patients? Because what we found is for the people who, the participants who were sampled among others, what they are planning to get to all the people living with NCDs, not only being in research, but for other day without data collection. Thank you very much.
Thank you very much. We shall have a round of 5 questions.
Thank you. My name is Ladislas Chimimana from Rwanda Biomedical Center. So I have a couple of 2 questions. The first question goes to Clarisse. I appreciated the study and the presentation. That's very important and timely important for treating the patient using precision medicine. Within the presentation, you mentioned that even the cost for the precision medicine is involved. I would like to ask, what do you think as a strategy to make a trade-off within the existing conventional treatment without considering precision medicine? What can we do within the health system so we adopt the precision medicine and considering the cost of what is required to have for applying the precision medicine? So another question goes to Dr. Brian on multi-month prescription of RAT. You mentioned that the multi-month prescription at 6 months was not associated with the viral load suppression. So what were the results behind about the viral load suppression? Does the outcome goes wrong? So was it wrong when you come to 6 months regarding the viral load suppression? What was exactly the results? Thank you.
Thank you very much. I want first to congratulate all the presenters for the good work that was done and for the nice results presented today. I have a few questions. Let me start with the one that goes to Brian Pizera. My question is a bit different from what my colleague just said. I observed that in the findings, the shift from 3 months to 6 months prescription has generated some benefits, including the number of people with target not detected increasing. So I would like to ask if you've been able to control other factors that would contribute to that viral load suppression, like the shift from other regimen to DTG, like Simeo presented, that it is yielding some therapeutic effects on patients on ART. I have other few questions for Clarisse. In regards to diversity among Africans, which actually is not taken into account while developing drugs. So I'd like to ask if there are enough evidences about therapeutic failures or failure to these drugs that were developed not taking into account the particularities of Africans. So if there are evidences you can share with us. Another question to you, Clarisse, is about the challenges implementing precision medicine, which include the cost, and I would like to understand much better about whether these parameters are considered on individual or on population level. So in case it is at population level, I think it needs some investment in doing some researches and establishing reference values for the population instead of considering individual variabilities. Thank you.
Thank you very much. Let's have...
the mic. I have questions.
Oh, okay.
Okay, thank you. My name is Mubaliza Mutagoma from
one.
Mugonero Hospital. I have one question to Clarisse. So that it is a qualitative research design, but in your result you focused more on quantitative results instead of qualitative results. How will you use those quantitative results in this study? The second question goes to Msafiri. The study on factors associated with hepatitis B and C. How participants were recruited among those NCD patients, the process of recruitment of those people. And second, you said that there is association with age and hepatitis C. Is it a cohort effect, or is it the vulnerability due to age? Thank you.
Thank you very much. So we have quite a number of 8 or 7 questions. We start by Musafir. The second question was addressed to Clarisse, the third one to Brian, and then the fourth, and the remaining again to Clarisse. So as I was mentioning by order, please. Thank you.
Thank you very much. Starting with my first question was asking the preference that we got from NCD patient. It wasn't really very less as the way I talked about comparing with the nationwide, because we found the preference for hepatitis C was 5.9. And the intention of doing a mass screening in paternal health, it wasn't the research as such. The intention of it was doing treatment. So for your question, the preference we got, it was a matter of doing treatment because we wanted to treat the hepatitis as infectious disease program. We are supposed to treat the patient with infectious disease like AIDS, HIV, HBV, HCV. So it is in that line we had to do the screening in those particular cases like NCD patients so that they can get treated. I did mention that we do have plan for our next paper. I tackled it about it. So it is about linkage to care and treatment outcome. That means that these patients, they were on treatment. They are on treatment. Sorry, many of them they have finished the treatment. So what we want to see is the treatment outcome if they have been treated. Because hepatitis C, it is treatable. The treatment are there so that they can be treated. That was the first question. And the second question he asked was, how about other NCD patients? So this is the reason, sorry. This, oh. So this is the reason we are here. We are lucky. So this is the reason we are here. We are lucky to bring in this one. Because we are lucky, we do have RBC here, we do have CHAI here. They are in charge of hepatitis. So what we are insisting, or we are trying to emphasize for the policymakers and even the other partners with Minister of Health is to use at least this method of microelimination so that other NCD patients from other districts, as I mentioned, they can be reached through this screening, so that any other patient who is out there with hepatitis at least could get a chance through this screening. I think I've answered that. And then my third question was recruitment of the patient. The patient, as I said, it wasn't a study. It was a matter of treatment. So if you are treating the patient, we had to inform them and make a communication, so that so that it is a part of the treatment. So the patient, they were lucky. Many of them, they understood, because it was the value of getting treated if they have that disease. So what we did, there was each clinical NCD clinical department from health centers, they have their patient. They have the list of the patient who always come monthly to get the treatment. So we had to inform them, to talk to them about this screening of hepatitis. So, and those one who agreed, they have to come for it. We didn't, it wasn't like consenting, doing what, no, because it's a part of the process of national Rwanda protocol of treating hepatitis C and B, so that every patient can reach out and get tested for HCV and HPV. That's what happened. And about age, so previous papers that we have been published, some bringing in publication and other thing, ignoring that we are not doing publication. So the publication we are doing, we do publication from the work that we have been doing. Then when we do work, like not the screening, we do screening and we say, why not? Why can't we share our findings? So then we do it in that way. So the factors, the last paper we did, we found that different factors, all even Sabe and Makuza, from their papers, they found that age is a risk factor for hepatitis C. Due to what? From previously all being a young age, we used to sharing some breads at home. We were sharing some needles. We were sharing different material that could make someone to get in contact with blood from another person from young age. And then due to our immune system, it can't be appearing when you are still a young age. It normally comes up when you have grown up. Age from 45 years and above. So that's why they say that age is a risk factor for hepatitis C and B. It's not that it is genetical, no, it's just from the previous exposures that you've had from the beginning. Thank you very much.
Thank you so much, Mr. Phil. And the remaining 10 minutes for Clarice for 4 or 5 questions that are addressed to you. And then Brian.
Yeah. Thank you so much, Dr. Garika. Thank you so much for the audience for posing some questions. The first one was about on costing of precision medicine in our health settings. And Radistras was asking what are the strategies that we can adopt to make sure that we are not blocked or hindered by the limited resources so that we can progress. I think engagement of partners and private sectors might be one of the ways to make sure that we can leverage efforts and advocate for funding in that way to make sure that we remove the gaps of infrastructure and other different gaps which have been observed in the health facilities. Other things is about using the existing resource that we have so far. As we mentioned, some of the respondents mentioned that at least we have basic infrastructures. We have some fair skills to start the process as a starting point. So I believe when you start, you always find the next steps instead of waiting. So the solution is to engage partners and make sure that we don't stuck where we are, complaining that we don't have funding. Just we innovate and we use what we have so far. And then on the question on evidence about failures of therapeutics, which did not consider genetic diversities of African population, this is a very good question. I can give an example of this treatment, tamoxifen, for breast cancer, for relapse of breast cancer. There are evidences that have shown that African population are tending to be triple negative for those hormonal receptors, and there are different mutations which have been reported to drive those kind of changes compared to other populations like Europeans and others. So with that, it has been reported that the African population tend to have relapse of those diseases, that condition, when they use the tamoxifen without checking the hormonal receptor status and those mutations. So that's one of the examples, but there are other different examples, like the one LDH, these low density lipoproteins, which are those markers used to control cardiovascular and hypertension diseases. So it has been reported that in African ancestries, they tend to react differently in the current treatment response based on the values or level of those LDH in the African ancestries. So I believe if we are able to generate more genomic data in African setting, we may be able to know what is causing resistance, what is causing failures to those treatments that we are getting, which are not, like at 6% are linked to one size fits all. So it would be good if we are able to have our genetic profile, which can be able to inform the therapeutics. Another question you mentioned is about if those studies can be conducted at population level or at individual level, and how those reference values can be considered. I don't know if I noted it very well. What I can mention it here is that studies have shown that African population are having low linkage disequilibrium, which is the key contributing factor for genetic diversity in that population. And also the population structure for our continent also is influencing the change and diversity that we are observing in the genome. So those two are forcing scientists to move into looking at diversity at population level instead of at individual level. So we hope that the more you generate data at larger sample size, like those genome-wide association studies, we may be able to detect those differences at population level. I don't know if I responded it very well. Then for the question for Dr. Mutagoma on asking how do we also present some findings on quantitative, and when it was qualitative, I would like to recognize that it's obvious that this was a qualitative, and even the sample size was very small. But what we meant here, we did the cumulative statistics just to make sure that it's a kind of presenting the findings, but we recognize that most of the findings are qualitative. We did just cumulative to make sure that we are presenting figures to check the levels of how they responded. Like on perceived barriers, it's obvious that those are different barriers, but we wanted to know how many or at which proportion with cumulative statistics have responded on those barriers and which one we can consider as priorities. But the study is qualitative and majorities of questions were open-ended. And then do I have, I think that's all for my question. Thank you very much.
Thank you. I'll take on my questions. The first question was asked about viral load suppression. I think there was a misinterpretation on viral load suppression. So, as the study title says, there were non-inferior outcomes. So there was no superior above. It was on average, the superiority was just the same. There was no superiority in both models. So as when our labs report viral load in 3 categories. So there's viral load not detected, which is viral load equals to 0. And we have viral load undetectable, which is less than 20, and then viral load suppression. This is how they are reported in our labs. Viral load suppression means less than 200 in Rwanda, but according to WHO, viral load suppression is less than 1,000. So we compared viral loads of these patients. And so we had a population of over 10,000 patients. So we are comparing the 2 models over a year, or period of a year. Those that were on 3 MMP, that also shifted on 6 MMP. How were they doing well in 3 MMP, and how well were they doing in 6 MMP? So the viral load suppression, for instance, in viral load suppression, it was 95.8 in 3 MMP model, and it was 95.4 in 6 MMP model. So you understand that there was just a slight difference. And in the viral load undetected, which is equals to 0, showed 22.7, and the other one showed 28.2. So, so what I meant, there was viral load suppression in 6 MMD model, as well as in 3 MMD model. There was just no any significant differences in these models. So that's what I meant by non-inferior outcomes of the study. So when I come back to the factors, if we were able to control the factors in the 2 models, I would say that when we are selecting our population, we selected 22 health facilities in Kigali. So this is where we get our patient population. And we did not base on what regimen they are on, so we could not tell whether DTG was the cause. We understand from Simeon's presentation, Dr. Simeon's presentation, that DTG has shown that there is great significance in suppressing viral load, which is a gold standard for to understand whether our patients are really suppressing. And given that, in further development of the paper, we want to see that we can control all those factors in the future studies. But for now, we can be safe to say that we did not include a certain patient population that is on a DTG-based regimen, and not those that were on a non-DTG-based regimen. So they were just randomly selected independent of which regimen they were on. Thank you.
Thank you very much. So let's have another round of 5 questions. We start by, yes.
Is this the one? There we go. Hi, I have a question for the team from UGHE. I think this is a really great and innovative project, but I was wondering whether you thought about adapting existing technologies before you launched into designing a new tool. In particular, I know that there are a lot of existing tools to help children who are not yet literate communicate that are already in existence. And so I was wondering if some of these tools might be more easily adapted to this setting than it would be to just make something brand new.
Thank you so much. I want to ask, I'm Auguste from University of Rwanda. I want to ask my question to Elsie and Clemence. So they have a good innovation really to help in clinical diagnosis as well as in dispensing But regarding to the application they are developing, I wanted to ask if they thought about how the patient we report the symptoms which comes and disappear, how the patient will really report those symptoms. The second question also I want to ask is about the patient who has both deafness and blindness, so how those patients will be able to report the disease. Also, thirdly, I see that the application will help those patients with deafness to report signs and symptoms so that the clinical diagnosis can be done. But how about dispensing? How in pharmacy or at the hospital, wherever, how the counseling during dispensing will be provided. Also, I wanted to ask how also those people with deafness who will have also the psychological problem will really report these symptoms. Thank you so much.
Thank you very much.
Okay, thank you. My question goes to the team from UGHE, RTA, and his colleague. They presented about a very good innovation, and my question goes to why did they choose to start from antenatal care? What were the data they based on choosing to start from antenatal care? Is where do you expect to get more users? Like, do we have many women who are deaf? Why did you choose to start by that program? Thank you.
Thank you. My question, we go to Gladys. I'm Justin, by the way, from Rwanda Biomedical Center. Gladys, thank you for your presentation, but I've got a question. With this precision medicine being integrated in our healthcare system, don't you think that there will be health inequity? For some patients who will benefit from meat more than the others. Thank you.
Thank you so much. One more question for this round.
Thank you very much. I'm Pacific from PIH. I want to address my question to the team from UGHE. I saw in your application, you have some pictures to show to deaf patients. I'm curious to know how did you come up with those pictures to determine whether deaf people will really mean the symptom by pointing at that picture. Thank you.
Thank you. Someone with a mic.
Thank you. My name is Fabrice Achizaez. I'm doing medicine level 2 in Huye campus. My questions are dedicated to the third presenter. It is about, actually I'm much concerned about public health. So I was asking myself if they are planning to expand their activities to other districts, and that's the question. And I was proposing that if they are planning to get to other districts, they would come at Huye. They are Huye students where we have at Huye, we have ability, we want to work. So as students, you can come and work with us. There are some uprising organizations which you can work with to promote the public health. Thank you.
Thank you so much. So let's have clarification and reflection from the presenters. The the first two questions from the Eritrea and Clemence, then Dr. Simeon, Clarice, and I think the last one was more of a comment and a request, not a question at all.
Yes, thank you so much for that bunch of questions. I will try to answer some and my colleague will help me. So the first, why not adapting existing technologies? And you mentioned one of that is already there that's used by children. So we are not aware of that, maybe to say that. But again, what we are aware is that they really are there, but the problem was that most of them are web-based, so they require internet. And on our search, talking to healthcare providers at the lowest possible levels, not all of them really had that internet connection. So the innovation of what our project will entail will be able to use that platform without need of internet. So that served as a solution. And again, other existing interventions that we saw were that they were using sign language. So you could go in the doctor's office, sign, and then a detector would detect those signs and transform them into the writings that the doctor would be able to see. And then the doctor will type again, and then the sensor will take those typings and transform them into the sign language that the patient can get. But again, throughout our surveys and interviews that we conducted, most of the patients do not know how to sign. So we came up with this thing that would help everyone. Even though you don't know how to sign, you can see the pictures, and the pictures would really help you. But we'll be glad to look up into that of the children and see if it can work here. And why antenatal care first, not other services? So this ANC really tackles two people, I'd say, the mother and the kid. So that would really mean a lot, helping mother and the kid at the same time. But also, according to the country's policies and programs, we've heard of how they really want to eliminate things like malnutrition. So we don't want those kind of people, I would say, neglected. We don't want malnutrition also there. We also don't want such kind of different diseases that would be found in those populations, because they also deserve to go with the national programs. So our first thing was to help two people at the same time, but also tackle those small things that the government, they're not small actually. Malnutrition is not a small thing. So helping two people at the same time, and then going with the country's vision of eliminating malnutrition and family planning, different topics that are discussed in antenatal care visits. And then we of course, planning to disseminate or continue with other services, especially reproductive and sexual health, or diseases related to sexual health. So they really need such privacy that we hope that our app will help. And then after, we'll be able to go into other services. Thank you, my colleague. Adam.
Thank you. So I'll start with the question that asks about how will the patients be able to explain intermittent symptoms, so symptoms that come and go. So that was a challenge. So there are things that can't be explained in words, but we had suggestions from some of our users that for some symptoms, we can use some videos. So if your symptoms come after eating, that can't really be displayed in a picture, but you can use a 3-4 minute, or 3 seconds video to explain that. So some adjustments are being done for symptoms that are hard to explain with pictures, with very short animations or videos. About blind patients, so our app, as we explained, it does need someone to see the picture. So it will not be able to be used by blind patients, that would require another intervention that is specific to people who can see. They also ask about other services and especially the pharmacy. So yes, we did see that deaf patients experience communication barriers throughout all the services, including the pharmacy. But as Ahitia said, now as the beginning, we are focusing on one service to see how it goes and improve from there. It doesn't mean that we won't get to other services. This is just the beginning. We will get to other services. How are the patients going to explain psychological symptoms? I think I also answered that. So for mental health, that's another service that will be covered as we improve and develop our project. The last one was about, so why did we use those pictures, and are they going to be cleared to the patients? So as we said, that's a prototype, and we are getting feedback, and we also try to, we're planning to get pictures that are more specific to our culture, so taking pictures from our people, going to our own patients and taking our own pictures. What we showed, that's a prototype. That's what we were thinking about. But the pictures, we can take them from our communities. I hope I answered all of them. Thank you.
Thank you so much. Clarice, the last one's for you.
Yeah, thank you very much, Dr. Garika. Thank you for asking that important question on health inequity. Yes, actually, we should expect that inequity in our setting, like in any other country which is in the journey of implementing precision medicine. Already there are some evidences that are showing that there are already inequity in using precision medicine within oncology settings, and especially when it comes to racial minority groups, which are not able to even do those genetic testing, or who are not capable to pay for those genetic tests, which are expensive. So if they don't do tests, it means that we don't have data, we don't have those genomic data that would inform in development those therapeutics based on those genetic diversity of our population. We should expect that health inequity as like in any other country which is in the journey of promoting this precision medicine. But as we grow, as the country is able to set up those infrastructure, and the community is able to access those genetic testing at fair cost, then we'll be able to receive those data, which should inform the whatever innovation or whatever therapeutic inventions which might be linked to our population. Of course, also when we looked at on the respondents' perceived barriers, they mentioned about even now they have issues of challenge of paying those 10% of copayment of health insurance. You can imagine when it comes to pay those targeted therapies, they are like expensive, and sometimes they are not covered by the current health insurance. So it's obvious that we face those challenges of health inequality because of our socio-economic condition and and the way we are progressing. But it's a starting point, and as we start, we find strategies. Thank you.
Thank you so much.
Sorry, I do have to answer a question from there.
Okay.
Yeah, he did mention about if we can expand our work to other district hospitals. I would like to tell you that PIH is supporting now 3 districts in Rwanda, which is Burera, Kirehe, and Kayonza. In particular, supporting more than 40 health facilities. and we are moving on to being supported in terms of Center of Excellence, where we do have like Burera District Hospital is supposed to be Center of Excellence for Oncology, and Kayonza will be supposed to be surgery and NCD. Kilehe will be supposed to be an MCH Center of Excellence. So with that, about the hepatitis C and B, we know that one of the main issues all the strategic plan our RBC is having is supposed, all it has in ongoing plan within 5 years until 2024, is that there will be elimination of hepatitis C. So it is working hard with other partners so that they can eliminate hepatitis C. So don't be scared of not PH being there in that district. RBC is working there. They are trying so hard so that they can reach out to anyone who is in need of being tested or screened for hepatitis B and C. Thank you very much.
Thank you so much. A round of applause to the team and the presenters. Thank you very much for the audience for your participation and attention. I would like to request you to stay behind as the presenters are moving to their seats. We are still having some closing sessions and awards to our most presenters and winners to the 3-minute thesis, and of course the closing remarks as we still stay in this room. Thank you so much.
Yes, let's appreciate our moderator for such a great work. It takes some hard work to actually get these great inputs from these presenters, and thank you so much for your work and for the work that has been presented here. This is a challenge. If you're not yet published, please publish, because if you do not publish, what happens? If you do not publish, you perish. So let's make sure that this work is not going to be wasted, but is going to be shared because it's a sign of what our country is doing. So yes, next to our agenda, we're having few agenda items, and I'm going to request again Dr. Ohol Nishimge to come and moderate the next session where we're going to award the best 3-minute thesis presenters. Can we appreciate her as she's coming, please? Thank you so much.
Thank you, moderator, for the introduction. And so we've come to the time of awarding best performers for our 3-minute thesis presentation competition. But before reaching there, I would again like to appreciate our participating student in this competition, appreciating everyone, Valence, Samuel, Ghislaine, Sion. We appreciate you for participating. And also, before announcing the winners of the competition, I would like to highlight the criteria of evaluation that was used by our assessors during the scoring as our presenters were presenting. We had actually a team of 4 assessors seriously looking at what our presenters were doing, and the criteria they had as follow. The first criteria that was based on was the quality written abstract. And this, they took marks that came from 3 reviewers who reviewed the abstract before they were accepted for being presented at the conference. and there was an average mark out of 25 looking at the quality written abstract of the research of our students. And the second criteria was the quality PowerPoint presentation. And they were mainly focusing on the clear build-up of the slides of our presenters. And they were looking at the good figures in the slides, if there were any. And they were also focusing on the clear text in the presentation slide of our presenters. And this was also scored out of 25 marks. They also had a third criteria, which is the clarity of oral presentation, starting with this 3-minute presentation that we had from our presenters, but also the clarity of answers to the questions that the presenter has got. That's why we made sure that at least every presenter get 2 questions at least. And then this was also scored on 25. The fourth criteria for evaluation for our assessors was the relevance and the potential impact of the research of this student. So they were looking mainly into if the research is publishable or it is tackling a relevant problem. So as we had our presenters presenting, they started by giving us the problem they are tackling, but also the assessors were also looking into the impact of this research and if it's worthy publishable. And this was also scored out of 25 marks. And this may make it a score out of 100 for all the competitors. So as I said, we had a team of 4 assessors, but we have 3 awards. So out of 5 presenters, we are going to award 3 presenters. So who do you think are the winners? Is everyone winning? It was not an easy task to choose among them, but because to start with, all of them kept time, as you noticed, and all of them were confident representing their research. So it was not easy to choose among the winners among our 5 presenters, but we had a final decision on who is winning depending on the criteria that I've just announced. So I will start by announcing the third winner for the 3-minute thesis competition. And the third winner is Mr. Eric Mugabo. Eric presented his research on exploring factors associated with research involvement of undergraduate students at the College of Medicine and Health Sciences at the University of Rwanda. So, and I would like to invite Dr. Vincent Chubaka, who is the Director of Research in Partners in Health, to come forward as Eric is coming forward also, as the protocol team is helping in giving the award to Eric. So many congratulations, Eric. So Eric has scored 70.4 out of 100. So many congratulations, Eric. And Eric is getting in the package a hard drive to help him advance his research. And I would like to call upon the second winner. And the second winner is, who do you think is? So our second winner is Samuel Nahimana. And Eric presented on detection of pneumonia by chest X-ray using machine learning techniques. And I would like to call upon Dr. Brenda Katela, who is the director of Clinton Health Access Initiative, CHAI, to give the award to our second winner. Many congratulations, Samuel. Samuel scored 75.7%. Congratulations, Samuel. And Samuel is getting in the package a tablet to support his research activities. And then our first winner is, do you have a clue of who is the first winner? The first winner of this 3-minute thesis competition that was held at the Digital Solution and Innovative Practice for Better Health, part of the health research, the 2022 Health Research and the Policy Symposium is, who do you think is that? So our first winner will be so our first winner is Siona Prasad. Congratulations, Siona. She presented her research on robustness of a visible image machine learning surgical site infection diagnosis algorithm when image quality is degraded. And I would like to call upon the Director General, Rwanda Biomedical Center, Prof. Claude Mambo Muvunyi, to come and award our first winner. Many congratulations, Prasad. And Prasad scored 82.5%. And she's getting in the award a tablet plus a hard drive to support her in her research. And I would now like to call upon the awarding individuals and some of the organizing committee to come for a group photo with our winners. I might join too. Thank you so much, and thank you for the organizing of this conference to give a space to our students to compete for this competition, but also to showcase their research and have an opportunity to build networks and collaborate with senior researchers. We hope this will go further for them. And for the winners and for all those who participated as well. We only had 3 awards, but I know you did all a great work. Thank you so much. I will now hand over to MC for the next session. Thank you so much.
Congratulations, winners. And next year there's another conference. I've heard that. Some people said about it. So if you are wise enough, my students, you should be able to win that for the next year conference. So thank you so much. I think this was super inspiring. Someone said in the morning that yesterday was inspiring, and I think today was also even more. And I am sure by the 3 people, they are just the start, but everyone actually should be awarded because the work speaks for itself. Without taking so much of your time, remember yesterday I invited someone to take us through the menu and the expectations. So this is the time we actually need to know whether the menu that was served really got to your expectations. So we're going to hear what we've been able to achieve during this 3 days conference. And I am sure you're going to be surprised as me, because the 3 days conference has really, really done a good job, and we have a lot that we are going to discuss, and also make sure that we have some call for actions. So I would like to call Dr. Jean-Claude Ngawonziza, who is the Division Manager of Research, Innovation, and Data Science at RBC, to take us through the meeting, what we got in this 3 conference. Thank you.
Yes. Thank you. Thank you, MC. And thank you all for being here until now. So I think it has been a very, very productive symposium. We are very happy that the way we prepared this symposium in very short time to really fit everything and have a very good interactive session like this. We are very, very happy, and thank you all for really making this successful. So I will not have a lot, so you will be patient for 5 minutes, max 7, to go through what have been running in here and what is the consideration for our next conferences or symposium. So next, please. So one, we were very glad to have our leaders, including Permanent Secretary of the Ministry of Health and Permanent Secretary of Ministry of ICT, as well as ES of Executive Secretary of the National Council of Science and Technology, giving remarks for opening session of this symposium. Then we were glad that we had an unexpected number of participants. We had around 200, 250 in-person attendees, as well as virtual participants who were moving 30 to 50. We were glad that researchers, police actors, academicians, health care practitioners, academia partners, which was a very sparkling event. It took place at the CMSH at University of Rwanda, and it was very, very good, where we launched this platform, which is really a platform intending to strengthen partnership and building the capacity of our students, as well as integrating them in the health system. Next, please. So as key consideration, key message, it is imperative to embrace ICT-boosted digital transformation toward achievement of a digitally streamlined health system. This is a key consideration from the session of digital solutions. It is essential that our essential role of leadership, clear vision, digital transformation strategy, investment, partnership and private sector engagement in scaling up appropriate digital technology that we have seen and still being developed. Research, teaching, and service delivery should work in circular mechanism, as we have seen, to inform one another and infuse innovation in the health service delivery. This is an important remark that we really need to put the strong evidence into practice. So multi-sectorial engagement and collaboration for a sustained investment in digital technology and culture of policy brief. I think it was also one of the remarks and a very good session. And we really need to develop this culture and strengthen in our next symposium in the sense of really having a session on policy brief, as this is taking the evidence into practice. Next, please. So next step, we see that we really need to expand the symposium to accommodate wider audience, both locally and internationally. So at the start, this symposium was a one-day event. Now we are happy that the 2 days was successful. Why not 3 days? So we really need to see how to expand this, and we are moving toward this. So we have to include disease specific topic and diversity sub-theme in coming symposium, which we hope could even move to 3 days. So we intend also to organize this event at annual basis and consistent period. As we said, the previous symposium took place in 2018, and in between 2019, 2020, 2021, there is years of COVID challenges and so on, but we really aim to make this event at regular basis, at annual basis, and within the period that we think can be convenient for many of people to attend this symposium. So we want to involve more partners in the organization and funding to ensure sustainability of the symposium. So this is a very important element where we see that we really need to work in hand with all our partners and see how to sustain this important event. Next slide, please. So as something that will be coming is a detailed recommendation, which we will be sharing through emails and symposium website. We also share with you a questionnaire, a survey, to collect your feedback on how we can continue improving this symposium, this event. Please, we request you to really respond genuinely on this survey so that we can keep improving, keep strengthening our event, making it more. So the last is that the photos that have been taken here will be shared throughout our website. Please go there and collect the package of photo for this event, and we hope that it will be online website by next week. So I think this is all, and I want to thank all the organizers of this event. I know my DG, we also thank the partners, but I want to highlight for the organizers who really worked day and night to make this event successful in a very short preparation period. I also want to commend the effort of MC, who really made this event very interactive, but also our moderators, the session moderators, who also really made our event so enjoyable. I thank you all, and hope to see you in our next year symposium that will be announced many days before it takes place. This was a short notice, but we hope the other will come 2 months or even 3 months before it takes place. And we really hope to involve international community and make sure it's improved and improved as we move forward. Thank you all for having all the time here.
Thank you so much. We've done a lot of work during these 3 days, and this work is not going to waste. It's actually a plan and a call for action. So I want to turn to your neighbor and ask your neighbor which organization or institution or where they come from. Please, if you haven't, if you're the same institution, it's fine, but just ask them. And as you're doing that, tell them, go and tell your organization to commit to this so that next year, your organization is going to be here. Please tell them next year they should come, next year they should come. And as you're going on Monday and giving a feedback to your colleagues, tell them that next year we're having a conference and they have to come. So I'd like to take this great opportunity. To thank you. Thank you so much for listening to me. It has been an honor to stand in front of you and speak. You've made it so easy. I thank the people that involved me for this occasion, and I really, really thank you. It's an opportunity that I cannot take for granted. Thank you so much. Because I'm not going to come back here, I'd like to welcome the Director General of the RBC to come and give us the closing remarks and our farewell remarks. Thank you so much. Let's appreciate the DJ a little bit better. Thank you so much.
Thank you very much, MC. I hope that your mothers, the patient that you treat did not miss you during these 3 days. Thank you very much. I think you have been very helpful to really moderate this session. So thank you very much. Maybe before I give my remarks, I want to give some other next step or next thing after this conference. I think the MC said very well. We need to not leave all those that we learn here, but we need to really go and implement what we have learned here in all our practices. That is one. Second thing, probably it would be good also if the organizer, we work together and probably publish those abstracts and posters in the supplement of one of the journals. So we are going to work on that also, so that we really publish all those abstracts and posters, with your permission, of course, to one of the good journals, so that we can really make also this available to people who are not around for this conference. So thank you very much. So dear partners, different stakeholders, dear colleagues, dear students and residents, Good afternoon. I think today marks the end of this second edition of the Health Research and Policy Symposium, which is an annual initiative established by the Rwanda Biomedical Center in the framework of promoting local research and also its translation into policies and also practical implementation. As this symposium is created to be a platform to reflect on digital solutions and also innovation practices for better health by bringing together healthcare stakeholders, including researchers, policymakers, implementers, but also all the partners in health. And we really appreciate that it serves the purpose. I think also I want to really mention that we were very privileged to be with some of our ambassadors, Ambassador of Japan, but also Ambassador of Belgium, who really were with us in one of the sessions. So I think for us, these 3 days have been momentous days where we think that we have seen, as Dr. Claude said, we have seen the birth of United for Health, which is something that I would not really like to miss expressing again in this closing remarks. That will be a platform that really is going to promote some opportunities for exchange between students, policymakers, researchers, so that they really keep that interactions. Then the 2 days also, during the 2 days of symposiums, we have really discussed, shared, and also learned about how to use digital solutions and also innovative practices for better health. So throughout the past 3 days, digital solutions and innovative practices were discussed, and different important points were also raised, such as one, for example, we need to make sure that with all the effort that we are putting together to really setting up ground for clinical trials. We know that there are some efforts that are already there, but I think Arabis is going to really drive all the effort to make sure that we have a good infrastructure for readiness and also training of human resources to really be able to run clinical trials. And we know that also we have been having also great support from the high-level office in terms of also giving us some opportunities for vaccine manufacturing plants. So as we are having those opportunities, we also have a pressure to really be ready for those opportunities. The second point that really came out of this 2 days conference, we also understand that we need also to strengthen our diagnostic capabilities. And when I came in this room, I was very glad to hear discussion around precision medicines by Clarisse. I think we need to also be sure that with all the opportunities that we have, how can we really build, for example, a very strong diagnostic capacity that's really make access to all the tests at all levels for our health facilities, but also at high level or the central level, how can we really generate data, like even from the sequencing data that could help us to really guide any investigators who is keen to really work on any biomarkers so that we really develop those vaccines and drugs. So this is something we need to make sure we implement in these coming years. Documentations and use of data is one of our priorities, not only for Rwanda Biomedical Center, but also for all the facilities. We're trying to see if we can be driven by data. And this has been shown from these conferences that data are very key, and we will continue to really promote the use of data at all levels of the health system. Networking, we need to continue this networking, and the MC said very well. You can ask your colleagues sitting next to you if we will continue these interactions. Not only, we don't want this to stop by here, but we really need to really continue to interact. I hope that you have made some encounters, and we really need to continue like that. We have partners in this room, we have students, we have also mentors, so we need to really continue this networking so that we keep this momentum of really sharing data, but also sharing some expertise. Flexibility to learn from the past experience is very key. I think we can't forget the experience that we learned from the COVID. COVID has really told us where we are not doing well. We need really to also learn from that experience and also be ready for next pandemic or outbreak. That means that we need to really make sure that if we have a very good diagnostic systems, do we have very good therapeutic for vaccines, therapeutics, but also vaccines to really be ready for next pandemic. So in the light of those achievements that we shared here, the government of Rwanda is also eager to maintain this momentum in delivering improved health services and also enhancing the general well-being of the populations. So in this context, I genuinely find that this call to engage really in generating and using research evidence for creating informed health interventions to drive particular attention to the pressing need and also effectively link researchers and also policy makers to the health needs of Rwanda, but also enhance the innovations and research capacity through digitalizations. So before ending my remarks, let me express my gratitude to all those who attended this symposium, both physically but also virtually, and also helped to make this a successful event. And our special thanks goes to the speakers. We have a great keynote speakers, and to all the panelists for their valuable contribution to this symposium. And finally, my deepest gratitude goes to all the organizing team, that include the UR team, RBC, PIH, CHAI, but also our other partners, because the data that we presented today may also be supported by one of our partners. And here, I really want to really thank also those other partners like USAID, ICAP, who have been with us for the beginning of this conference, Enabel, and any other partners that probably I could not mention, because without their support, we could not really generate data to really share during these two-day conferences. So again, thank you very much. I know that I don't want to take much of your time, and remember that we need to really make sure that we continue this networking, but also continue to really improve the way we are using data, and also those data need to be of good quality, and RBC is really open to any great ideas that you may have, and sincerely, I want to tell you that we are very open to any visit to RBC. We are open to anyone who is in need of data to improve the practices. So feel free to really bring ideas, and we'll be ready to really work together and also really improve the use of data so that we can have policies that really have actions and also can be translated into the management for patients. We have many gaps to fill, and I'm sure that all the partners in this room will be asking us to be sustainable. And I'm sure that to be sustainable, we need to really use data to identify areas where we need to put much effort, but also to maintain all the achievements that we have registered. So I don't want to really lose or forget the achievement we have achieved in HIV, for example, and also putting much effort on COVID, for example. So we need to really be creative and strategic so that we really continue to improve the well-being of Rwandan populations. So on behalf of MOH and everyone here, so I would like to really thank you for this, for giving your time to be present here. And also I wish we'll have the same kind of conference next year, but also many other conferences like this, so that we can really share data that belong to Rwandans. Thank you very much again. I'm really pleased to, on this note, to really declare this conference closed. And I will invite you. I hope that the organizing committee has also prepared something to refresh yourself. And I hope that the MC has really been very, maybe has something to also take and then really be relaxed now. So everyone is really invited to really, again, continue to networking, because around a glass of, I don't know if it's water or tea, but maybe the team will let us know. So thank you very much again, and I wish you all and a good weekend for now. Thank you very much.
I thought I was not coming back, but I'm sorry. So there's a networking cocktail that is served outside. And also what used to be our coffee break. So please do not leave.